patients who present with hemolysis with paravalvular leak are very have poor prognosis, because many of these patients, even after arresting the paravalvular leak, they continue to have hemolysis and they don't do well in long term. But paravalvular leak patients who present with heart failure, once you close the device and make the leak as minimal as possible, these people do long term very well. Other important thing is even small leaks in the presence of non-compliant chamber can also present clinical symptoms in this group of patients. What about the recommendation? ACCH 2014 guideline recommendation is class 2A, paravalvular closure for high risk surgical patients with intractable hemolysis, or NYHA class 3 or class 4 heart failure in anatomically suitable patients performed by experts in these procedures. The key to success is very important is proper imaging, and if you have a 3D in your lab, it will be good to do these procedures, because the sizing and exact position, how to process device will be easy, and meticulous spanning should be there. Hardware and device selection is very important. Evaluation of this patient is a challenging task. So as I said, we need a transthoracic esophageal echocardiography with a 3D reconstruction if possible. And especially in aortic paravalvular leaks, if you do a CT, we can exactly define the size and the tortuosity or any presence of calcification in the paravalvular leak. All these things we can know. Aortic angiogram just to know whether how well define the leak. And the other important thing is size of the leak, the shape, the number of leaks, circumferential extent, location, and relation to prosthetic wall leaflets. All these things we have to evaluate before we go for a closure of these leaks. And other important thing is sometimes we get confused with a significant valvular regurgitation with the paravalvular leak, and this can be made out by the rocking movement of the wall and active endocarditis. These two conditions, if there is a rocking movement of the wall and infected endocarditis, we should not attempt for a paravalvular leak. This is an echocardiogram which shows a paravalvular leak 9 into 6 millimeters, and the below picture shows the severe paravalvular leak and the patient with a dilated left atrium and left ventricle and presence of a PAH in this patient. And if you see, this is a crescent shaped leak with multiple openings, and we have closed this leak, and you can see there is a one device and there is a leak there, and there is a first device and this is a second leak. So we have to keep two devices in these patients. Otherwise, this patient will continue to have a paravalvular leak. Some important points to know before you do this device: the nature of wall used and its orientation we should know, this is very important. The surgical sutures used, the orientation and shape of the prosthetic walls are other important. In the tilting this wall in mitral position, we will have a major orifice towards the left ventricular free wall as opposite to the septum. Whereas in aortic prosthetic wall, the major orifice orientation is towards the right posterior aortic wall. But this varies from wall to wall. So, but we should know that what is the orientation of the wall to do a good device closure. And this is how the where common place where the leak occurs. If you see the clock face delineation, and if you this is not the pointer is not pointing the screen anyhow. So if you see clockwise delineation, and aortic leaks are more common in 7 and 11 o'clock position, 46% of the patient, and between 11 and 3 o'clock position in 36% of the patient. Whereas mitral wall leak is more often present in 10 to 12 o'clock position, 10 to 2 o'clock position in 45% of the patients, and in between 6 to 7 o'clock in 37% of the patients. This is how we see the wall in TE and the surgeon's view, and this is how we have to know where the leak is occurring. Hardware selection is very important. You need a septal puncture kit if you are doing a mitral leak, thermoglide wire, and you need an exchange line, and then you need ampliager exchange length wire. The snares, you might need all the three types of snares, and you need a long delivery sheath when you do aortic valvular leak. That's very important. If you don't have in the shell, you should have this 100 centimeters leak. These are various things you should have in the lab. Cook shuttle sheath, flexor sheath, they're very good sheath, and there'll be 100 centimeters. You need snares, any type of snares can be used. You need a glide wire, you need a septal punctures, you need a ampliager stiff wire. The steps and methods of aortic valvular leak: retrograde femoral approach is commonly used. Coronary angiogram is important to delineate the ostia so that the coronary occlusion doesn't occur. You cross the lesion, the valvular leak, with a hydrophilic thermovide followed by sheath passage. In case of difficulty, you do a railroad technique, transeptal technique, or through transapical approach. Mitral valve weak, you can do either antegrade or retrograde. Retrograde is through the transeptal approach, that is retrograde is through the aortic wall, directly through the aortic wall you can cross, and antegrade is through the transeptal approach. So it's important to preserve the iotrometal continuity by covering wire with catheter as far as possible. The choices of devices, there is a lot of choices: muscular VSD occluder, duct occluder, Amplage AVP plug 3, ASD occluder, and AVP 4. But now we have a new device which is specific for paravalvular leaks, and this is from the Chinese company, and this is now available on compassionate basis. Still it is not FDA approved, but if you want, you can, if you tell the company people, they will arrange the device within 1 to 2 weeks. This is Acute paravalvular leak device. The technical success is 77 to 86% in expert's hand, and 67 to 77% there is a clinical improvement. Long-term survival at 6, 12 and 18 months is 91, 89 and 86% respectively. Whereas other groups found 1 to 2 survival rate after paravalvular closure is 70 to 75% and estimated 3 year survival rate of 64%. Many of these patients are very sick, that's why even though after closing leads they don't do well. Just some of the examples which we did. This is a case 1, 71-year-old, 55 kilos, and he had a bioprosthetic aortic wall, and he had a paravalvular leak with class 2 symptoms, and he had a 4 millimeter aortic paravalvular leak, and this is the defect in the 3D echocardiogram in the aortic position. And these are the baseline procedures before and after. There is a significant pulse pressure, and after the closure the pulse pressure improved. So this is a well functioning prosthetic aortic wall. Then there was a leak and we did angiogram. There is a sufficient height, that's why we didn't had any issues, and this is a paravalvular leak with aortic prosthesis. So we crossed the leak with the thermo wire, but the catheter was, we couldn't cross the leak with the catheter, even though 5 French guiding we couldn't cross. So we have to do a arterial loop. So we cross the bioprosthetic wall and snare the wire, and this is how we cross the leak. And this is we crossed the wire through the bioprosthetic wall, and we made arteriovenous loop, and we snared it through femoral artery from the left leg, and this is a loop. And once this loop is formed, we could cross with the sheath here, and then we deployed the ADO2 drug deployer was deployed. And this is a second case where a mitral paravalvular leak, and this is a patient with ASD closure with mitral valve replacement, and we did a septal puncture, and we have crossed the leak with a thermo wire, and this is a Amplage wire, and there is a PDA duct occluder, introduction of the device. There is a duct occluder, and we have closed the device. This was another case where multiple defects were there, and we have to go through the antegrade approach. And this we have crossed to the antegrade approach, and we have snared the wire in LA, and then we formed a loop, and we deployed one device, and this is a second device we are deploying here. And you can see that after deploying 2 deploys, you have to be very sure that there is no interference with the mechanical leaflet. You can see the prosthetic wall movement, and you can see in the last one the prosthetic wall is opening well, and there were no gradients, and patient did well. The complications is prosthetic wall leaf impingement can occur in 4% of the patients. You have to be very careful. Device ambulation can also occur. Coronary obstruction can occur. Bleeding or hemothorax, especially in transapical. And then unsuccessful procedure, main cause improper imaging and lack of suitable hardware. This is the last picture. The aortic wall patient where we try to deploy the second device, and after deploying the second device, the device got embolized, and then we snared the device. These things all can happen, so you have to be ready for all these complications and know how to remove these embolized devices, and they will successfully removed. We have done 13 cases, various aortic wall and mitral wall combination, prosthetic and mechanical, and we were successful in 10. 3 we couldn't cross. All aortic wall we did retrograde closure, and mitral mostly we did antegrade. 3 we couldn't do it because we're not able to cross the defect. One patient developed hemolysis later. One unsuccessful case we sent for surgery. So the message is device closure of paravalvular is acceptable mode of treatment in expert hands. Meticulous imaging hardware selection is key for successful outcome. Various types of plugs are available for specific shape and type of paravalvular leak. In case of tortuous paravalvular leak, difficult to negotiate catheter, a arterial loop through a prosthetic valve is recommended with caution. This can be done only in a situation of bioprosthetic valve, and a mechanic valve we cannot do this. Thank you very much.
Thank you, sir. I think the questions will be allowed at the end of the session. Now Dr. Gokhale is called upon to speak on See, he's going to tell us how to repair the mitral valve. Who suits the scenario?
Respected chairpersons and delegates, good morning to all of you. This is another topic which I can see in the next few years will slowly slip away from the surgeons, and we hear more and more about percutaneous ways of handling things, maybe a few years from now. But for the time being, still surgery remains to be the procedure of choice for handling mitral repairs. You know, we all know there are two things we have as surgeons. Whenever a patient has got a mitral problem, either we do a repair or replacement. Most of the times we end up doing replacement for various reasons. But repair, we know, has definitely some advantages compared to the replacement, especially in certain group of patients, in certain economic strata, and in the hands of good surgeons. You know, there is a better preservation of LV function, and the prosthetic valve related complications are less, and then long-term problems are less. All these things are very well known. But of course, there are a few things. What are the techniques we have to take depends upon 3 or 4 factors. One is the type of surgeon, the second is the etiology, what causes. The third is what helps us most of the times is a Carpenter's classification, functional classification. And next is, of course, the anatomy of the valve itself. Based on these 4 things, the results evolve. But whatever it may be, end of the day when we do a repair, there should be a good approximation of anterior and posterior leaflets, there should be good mobility, there should be no stenosis, and often annular dilatation also need to be handed over. And if there is any infection, we need to remove the focus of infection. These are some of the general principles. We know the commonest problem where repair can be offered is the degenerative for various reasons. In the degenerative, the commonest problem we find is the posterior caudal rupture. The second, of course, is the annular dilatation. As you can see here, percentage, about 49% patients have got posterior caudal rupture, and at about 24% have got elongated cardae, and the next combination is the dilated annulus. That's how we analyze what is essentially makes it is we had 2 holes instead of 1 hole, provided that we don't produce stenosis. It actually bails out many of the patients with a degenerative etiology. Compared to the rheumatic, which is very common for us, of course it's becoming less common than before, but the rheumatic is a little more complicated. There are very few surgeons who do a proper repair in these, and of course I'm not one of them. I do not have a lot of experience. My experience of rheumatic is very restricted. But here there is a combination of mitral stenosis and mitral incompetence. Both of them need to be repaired. The pathologies like calcification, shortening, commissural effusion. There are multiple pathologies that are involved here. We have to use different things like cuspal thinning, commissurotomy, enlarging leaflet of the pericardial patch, excision of the basal cardae, decalcification, artificial cardae, annuloplasty. Various combinations of these need to be used. And this is some of the diagrammatic representation. And one of the largest series in this country is from Professor Sampath Kumar from All India Institute, where he has done in about almost 900 patients, he published his results. The commonest problem he found was the annular dilatation 80%, leaflet prolapse 30%, calcification 4.3 patients. And the long-term survival from his paper, the long-term recurrence rate from mitral incompetence, all these things have been extremely good. Of course, many people could not replicate. There are few surgeons, especially in Southeast Asia, where they are able to do it, but not many. With quadrangular resection, the results seem to be good. But basically, the durability of all these things depend upon the valve anatomy, pathology, and the surgeon. These are the factors that play a role in repair. Especially degenerative can be offered, and to some extent infective endocarditis, and next is the coronary artery, ischemic MR. These are the procedures where we can offer repair with reasonable results, whereas the rheumatic still remains difficult for most of us to do the repair. Thank you very much.
The next speaker, Dr. Kapardi, can you just speak on TAVI?
Good morning, chairpersons, moderators, and delegates. So today my topic is transcatheter aortic valve replacement. Usually in the Western world almost it is very popular, but in India after DGC approval of 2015, now it is increasing in incidence in India. The only thing is cost is the main limiting factor. But nowadays the Indian native valves, their Indian valves are coming with the middle company Myval as well as the Hydra vascular concepts. Now it is slowly, in future we are expecting the cost will reduce and increasing in these implantations, may occur hope. So with this introduction, just I want to deliver this lecture of transcatheter aortic valve replacement. Yes, sir. Okay. Right. So, usually we did one case. Nowadays, under the proctor help only, first 30 cases we have to do. Dr. Casco, who himself is a surgeon, with his proctorship, we did one case. The case details is as follows. The patient, age is 72 years old gentleman, having diabetes and hypertension, had exertional breathlessness class 3 with induced ischemia TMT. He had echo-wise mild calcific AS 1 year back, mild LV dysfunction, and angiographically triple vessel disease, underwent bypass surgery in March 2016. And he became asymptomatic, and he had recurrence of shortness of July 16. He underwent again angioplasty because of the lesion of SVG to RCA. At that time, echo showing moderate AS. This is in other hospital, it happened. And November 2016, he presented with recurrent LVF with repeat admissions with LV dysfunction, severe LV dysfunction, dysarthria, which is effectively managed. And at that time, the echo showing severe calcific aortic stenosis, the aortic valve being bicuspid called with LV dysfunction. So this patient, we did the echo. It is a severely parasternal longus showing the severely calcified right coronary cusp, and it is a bicuspid valve. And you can see, usually bicuspid valves, there is a fusion of non-coronary left coronary cusp will be there, but in this case, this is slightly anomalous. Left and right coronary cusp become fused with raphe with a heavily calcified valve. And the measured gradient in echo is, peak gradient is 70 and mean gradient of 40 millimeters of mercury. And cath, it is showing almost 50 to 60 millimeters of the systolic pressure gradient, indicating severe aortic stenosis. And LV dysfunction and producing this type of gradient means there should be a afterload mismatch. Definitely patient will become benefit means of aortic valve replacements. So this is the scenario now. Replacement, refused for surgery because of severe displacement and recent bypass surgery and angioplasty. But cardiologists never lose the hope. And anything a cardiac surgeon can do, an interventional cardiologist can do, as well as better percutaneously. So the first human implantation by Alain Krebir in April 16, 2002, successfully did in France with a bovine pericardium valve of 23 millimeters diameter. And this is the area where the cardiac surgeons and cardiologists in a hybrid suit, along with the multidisciplinary radiologist, echocardiographist, and anesthesiologist will do this procedure. And once we decided to implant a percutaneous valve, so this is the important, I will concentrate mainly how to select the case and important steps I will concentrate. So this is the CT angio protocol for TAVR, where you have to evaluate almost starting from the LVOT to the vessels so that you can select the axis also. So LVOT measurement most important is rare cases septal bump may be there which may sometimes cause a pop-off of the device. So you have to see for the LVOT any septal bumps are there. Second is the annulus dimension. The measured annulus dimension is most important. Here in this given case, it is almost mean dimension of annulus diameter 26.4 to 26.7 by diametric method and perimetric method. So how to select I will tell. And second important is sinuses is important, whether it is roomy or not. The dimension of the sinuses, the dimensions of sinuses here is 33 to 33, it is roomy. And the height from the annulus to the sinuses height, it is 24 to 27. This is also adequate so that coronary arterial obstructions won't occur. And second important is aortic root dimension is also important, ascending aorta, that is tubular portion, so which is no significant post-stenotic dilatations. All these are important selection. And the next important is aortic arch, that is also important, so that any atheromatous plaques will be there, carotid embolism we can assess. And most important, femoral and iliac artery sizes, where it is more than 5 millimeters, it is adequate for the transfemoral access. So this is the angiographic assessment of the annulus. Here it comes at 26 millimeters, and the sinuses whether roomy, and LVOT as well as ascending aorta, there is mild posterior dilatation. And this you can see the bicuspid valve where the right coronary cusp and the left coronary cusp are fused with Raphe along with the heavy calcium, and this is slightly atypical variant of routine bicuspid valve. And height from annulus to the ostia and sinus heights, which are adequate in this given case. So, and also important is angle actually between the annular plane, so which is less than 70 degrees, which is suitable for the aortic valve replacement through the femoral arterial route. So this is the femoral artery, which is a speck of calcium with adequate size with a minimal tortuosity, so indicating that femoral artery access is the suitable. So after evaluation, most important is the size of the selection. There are, once we decided to take Evolutar, which is a self-expanding nitinol frame valve, the four sizes available 23, 26, 29 and 34. Here the measured it came 26. So 23 to 26 we selected the 29 millimeters valve. So this design is basically the upper one is open design, lower one is the pericardium, porcine pericardium skirt will be there. Which will fit into the annulus as well as the sinus portion of the valve. So this is the procedure as follows. Once we selected left femoral artery, we put the 7 French femoral artery in a sheath, and under the guidance, this is most important because we want to close percutaneously by means of proglide. So we guided approach almost fluoroscopic or ultrasound guided puncture of the common femoral artery or the femoral head should be done, so that to prevent retroperitoneal hematomas as well as the hematomas of the thigh. So once after putting the 7 French sheath, we graded dilatation by means of 7 French, 9 French, 12 French and 14 French sheath we implanted. Then left femoral venous root, we put the balloon tipped guiding lead, actually the pacing lead in the RV apex. So latter most important step, left femoral arterial root, we put marker pigtail in the non-conversation. This is the most important step because it will guide the deployment of the device accurately in the LVOT and annulus. This is the most important step. And after that, when we actually the device, once we crimped on the delivery device, we have to check whether it is correctly crimped or not. By means of, we have to check by fluoro check the device. Then subsequently we cross with the ampelage catheter, the wire distal flexible tip wire into the LV and exchange with the marker pigtail in the LV. and we took the simultaneous pressure gradient which was shown around 50 to 60 peak to peak systolic gradient. Then later we exchange the pigtail with a Landerquist wire, which is the extra superstitive wire over the amplage extra wire. And here the most important step is pre-dilatation. Normally, routinely for tri-leaflet valve, usually posterior dilatation, we won't do pre-dilatation. But a bicuspid valve as well as heavily calcific, you have to do pre-dilatation. Undersized dilatation is important with 18 millimeters because it will facilitate the entry of the device. Then later we took the device, and most important is whenever it is crossing the aortic arch, you have to carefully check whether we have to, most important, the atheromas or anything we should not displace, or so that carotid embolism we can avoid. So this is the TEE guidance we did, where it is showing eccentric orifice with heavily calcified with a trivial AR and stenosis. And this is the most important across the aortic valve. And this is the most crucial step which we have to spend the time. So where once 6 millimeters you should be projected into the LVOT for routine tri-leaflet valve. For the bicuspid slightly higher the orifice, so 3 millimeters should be projected with a constant fluoroscopic guidance. So this is the one. Once after the correct deployment, what we have to do is stepwise we have to deploy by means of anti-clockwise rotation of the hub of the delivery device. Slowly this will open. Then initially once it will occlude the orifice, the pressure will drop down. But after 80%, yes, this is the one you constantly fluoro check for the correct place of the deployment or not. This is important step. But if you are not satisfied, again you have to readjust. So these the nodes distance from the marker to the distal tip is almost 6 millimeters. So that should be projected, 6 to 3 millimeters should be projected into the LVOT. Once you are satisfied, you 80% you can deploy. After opening of that skirt, immediately the pressure will rise. And once you are satisfied with this fluoro guidance, then you can deploy finally in LAO. Yes. After completion, then you can exchange this, you can remove this Novacon, 2 minutes. And this is the final step with the pigtail. You can take the injection. So there is a trivial AR, and almost the gradient become 0 with the simultaneous gradient across the aortic wall. So this is a transthoracic showing a no turbulence across the this valve, and this is a trivial AR it has seen. Most important is the gradient become 1.5 to 10. If the residual gradient is more than 15 millimeters of mercury, you have to do post-device dilatation to prevent the paravalvular leaks, reduce the incidence of paravalvular leak. So this is the most important is heart team approach is most important, first and foremost indication for TAVI, where the surgeon as well as cardiologist will converge in this type of device, and where the cardiac surgery is not on-site is not there, it is not an indication, it is a contraindication. So all prohibitory high risk or high risk patient with a STS score of more than 8 is an indication for the TAVI, where the surgical risk is phenomenally high. And of course, absolute contraindication, estimated life expectancy less than 1 with high frailty index, and anatomical, of course, annual size of less than 18 millimeters and thrombus in LV and active endocarditis. Others are nowadays, they are not saying, because even bicuspid and heavy calcified also doing. And most important, there's 2 important valves. One is balloon expandable, there is Edward Sapiens 3, nowadays 3rd generation, which will minimize the complications. And Medtronic core valve is that is initial, the 1st generation. Now this Evolutor is the advanced 2nd generation valve, which minimizes the complications. And here the 3 types of accesses: transfemoral access, as long as the femoral artery is suitable. If femoral artery is not suitable, you can approach left subclavian or transaortic, especially if the angle is less than 70, you have to use transaortic approach also. So these are the complications which minimize it after the 2nd generation valves, especially conduction abnormalities, almost 1 to 3% it was there now with recent generation valves, and of course arrhythmias. And important is paravalvular leaks, which you can minimize by means of post-device dilatation. And coronary occlusion, if they are suitable, the annulus to the coronary ostia height is more than 10 millimeters, usually incidence is less. If it is less, you have to project the coronaries so that you can prevent the coronary occlusion. And embolization, device embolization also, small incidence it is there nowadays with the self-expanding as well as the second generation balloon expandable valves. And mitral interference also, if it accurately positioned, it won't interfere the coaptation of the anterior mitral leaflet. Rupture of artery, very important is you always do the dilatation undersize or post-device dilatation also, equal annular size you should do, you should not post size, so that this is one of the dreaded complication now with minimized with the recent generation, the valves. So these are the different complications now minimized with the advanced generation, the valves. Caution, always cardiology may be closer than they appear. Now they convert the cardiologist with this device and increasing the successful rate for the patient. Thank you.
We'll have all the discussion towards the end, Dr. Kapade. Please have a seat. Dr. Kapade is here. Please. He'll be talking to us about the timing of surgery in multivalvular heart disease.
Good morning, everyone. Let me introduce Dr. Kapadia. Presently, he is working as a chief cardiac surgeon and cardiac transplant surgeon at Kokilaban Hospital, Mumbai. He is a very close friend of mine. When I requested him, all the way he came, I request all of you to give a big round of applause. Thank you. You can come.
Very good morning, chairpersons, delegates, my colleagues. I and Dr. Gokhale, we were together in CMC Vellore many years ago. And this is really privilege for me to be here. I'm the member of CSI since 1997. So I have been closely associated with this organization. The slide. Okay, I got it. So as we know that rheumatic heart disease incidence in India is on decline. Heart failure incidence is rising. Dr. Gokhale already told about. We have close to 25 million plus cases of heart failure in India. We see more and more cases of mitral valve regurgitation. In these cases, sometimes even tricuspid valve regurgitation. Many times we discover that this is not the valvular disease, this is the myocardial disease. Coronary artery disease is contributing more and more cases of ischemic MR and heart failure leading to secondary mitral regurgitation. And that needs a different approach. So what are the causes of valvular heart disease? Rheumatic heart disease, congenital, infective endocarditis, ischemic, traumatic, heart failure. And many times we get type A dissection, type A dissection, acute and chronic, associated with the aortic valve disease. So practice guidelines have taken some of the guidelines from 2017 American Heart Association, ACC, which is update on valvular heart disease. Some of the modification is done based on the European Association of Cardiothoracic Surgery. So class 1, class 2, all these indications, all we know. The heart valve team and heart valve centers of excellence, whenever there is a patient of valvular disease, it has to be referred to a center who are doing actually more and more work and they have experience. Now, taking the example of the aortic stenosis, the aortic stenosis in bicuspid aortic valve, many times these patients are asymptomatic. Now, unless they are symptomatic or mild to moderate leaflet calcification or gradient more than 40, there is no indication of surgery. But if they develop endocarditis, yes, there is an indication of surgery. Now, even in asymptomatic bicuspid aortic valve disease, if there is a calcification or the gradient more than 40, there is an indication of surgery, particularly if the LV ejection fraction is going down. Now, many times there is a hypertension which is uncontrolled. They develop severe LVH, diastolic dysfunction. In these patients, they may have very much symptomatic. The symptom may be primarily because of the hypertension, should be controlled with the medical therapy and then reassessment done. Timing of intervention, if the gradient is 25 to 40 millimeter of mercury mean gradient in presence of severe LV dysfunction, AVR is indicated, otherwise more than 40. Now, AVR is also indicated for asymptomatic patient with severe aortic stenosis when the LV ejection fraction is going down. Now, timing of intervention, AVR is reasonable for asymptomatic patient with very severe aortic stenosis and who are low surgical risk. And if the risk is high, of course, the TAVR is indicated. Even the AVR is reasonable in symptomatic patients who have low flow, low gradient, severe AS, stage D3, and moderate AS. So these are the indications. To sum up, AVR is class 1 indication if gradient is more than 40, asymptomatic patient or symptomatic with severe LV dysfunction, moderate LV dysfunction, recurrent syncope, or they have episodes of complete heart block, transient complete heart block. The choice of surgical or transcatheter intervention already discussed. So AVR, surgical AVR is indicated in low surgical risk patients, while TAVR is indicated in patients who meet an indication for AVR for AS, who have prohibitive surgical risk. And the post-TAVR results are predictive survival more than 12 months. Now, percutaneous aortic balloon dilatation may be considered as a bridge to surgical or transcatheter AVR in severely symptomatic patient with severe AS, but this is the class 2B indication. Now, chronic regurgitation, bicuspid aortic valve, disease of the aortic sinuses or ascending aorta. If dilatation of the ascending aorta more than 45 millimeter, there is an indication. Now, dilatation of the aortic sinuses or rheumatic valve changes in the sinuses, previous endocarditis. Even in moderate AR, there is an indication of surgery. Chronic aortic regurgitation, even in asymptomatic patient, severe AR with the LV ejection fraction less than 50, or if the LV dimensions are more than 50 millimeter, there is an indication. Now, I will not go into all these details, but severe AR is sometimes associated with the ascending aortic dilatation. They require root replacement of Bental procedure. So, aortic regurgitation diagnosis, particularly T is indicated if there is a doubt about the dilatation of the sinuses and ascending aorta, particularly with the bicuspid aortic valve. Medical therapies is started to optimize the outcome by reducing the risk factors. Hypertension is controlled with the drug therapy. Severe LV dysfunction may not improve unless the surgery is done for the AVR. Mortality is relatively high in these cases. Now, medical therapy to optimize, particularly to control the hypertension, AC inhibitors, beta blockers are reasonable in patients with severe AR who have symptoms and LV dysfunction, and later they can be operated. AVR is indicated for symptomatic patient with severe AR regardless of the systolic function. These are the class 1 indication. Is also indicated for the asymptomatic patient with chronic AR and LV dysfunction, LVEF less than 50%. AVR is also indicated for patient with severe AR who are undergoing other cardiac surgery like CABG or mitral valve disease. So it is reasonable for asymptomatic patient also to undergo AVR if the gradient is already discussed more than 40. This is to sum up. Now, bicuspid aortic valve and aortopathy diagnosis follow-up. Many times we keep following up this patient with the minimum gradient less than 25, then the gradient slowly goes up to 40. They get calcified, sometimes they have episodes of fever and endocarditis. The aortic ascending aorta actually start dilating more than 45 millimeter, and we keep observing. Recently I operated one patient who was under observation, who came with their acute type A dissection, and it was a difficult dissection to repair. In patient with aortic diameter greater than 4.5 centimeter, the evaluation should be performed annually. So, ascending aortic diameter, as I said, more than 4.5 centimeter with dilated sinuses of Valsalva, early surgery of AVR plus minus Bental is recommended, especially in patients recently operated for type A dissection. I just now said about this patient, and in fact he had a TE a week ago and he was severely hypertensive and he was not taking his medication. Bicuspid aortic valve, I won't go into all these details because I had to cover mitral stenosis. Mitral stenosis in fact is a multivalvular disease. As most of the cases the tricuspid valve is involved. commissural fusion and diastolic doming of the mitral valve leaflet with MVA more than 1.5 centimeter, square centimeter. We can wait for the surgery. In this patient, the PA pressure is normal, but if the mitral valve orifice is less than 1.5 square centimeter, moderately severe stenosis, or less than 1 centimeter is very severe stenosis or critical, then they are associated with the severe LA enlargement, elevated PA pressure more than 30. They are certainly a candidate for the surgery, or preferably balloon valvuloplasty nowadays is a safe procedure. Closed commissurotomy, some cases, selected cases. Now, mitral stenosis diagnosis and follow-up. Mild stenosis can be followed up by annual echocardiography, and presence or absence of left atrial thrombus, and further evaluate the severity of the mitral regurgitation. Now, in patients who are having mitral stenosis with the clot in the LA, or if they have got atrial fibrillation with the history or without history of stroke, they are the candidate for the open surgery. Otherwise, they can be managed by the balloon. So balloon mitral valvotomy is recommended for severely symptomatic patient with severe MS and favorable valve morphology. They are non-calcified, minimum subvalvular fusion is there. There is no clot in the LA. They are in sinus rhythm. Just 2 minutes. Now, I will quickly go to the pulmonary tricuspid valve regurgitation, which is a secondary. Now, we talk about the mitral valve regurgitation functional in the heart failure, and many patients, they are referred to us, and we think that this is the mitral valve regurgitation which is causing the LV dysfunction. In fact, it's not. And if we involve into the mitral valve repair of this patient, the mortality is close to 30%. So, recommendation for this kind of patient is to assess the myocardial function by the cardiac MRI and the other metabolic function of the myocardial muscle. Chronic mitral valve regurgitation, we have to do follow-up, mild to moderate, we can wait. Severe, they need valve replacement and preferably repair. I think I will end here. The tricuspid valve disease actually is the secondary to mitral valve disease, and they always require attention because mitral valve stenosis, if you don't address the problem of the tricuspid valve, 30% of the patient, they will have residual pulmonary hypertension, and they will have continue to have tricuspid valve regurgitation. Thank you very much.
Thank you, Dr. Kapadia. Please have a seat. This session is open for discussions. We are a little behind the time, probably one or two couple of comments, one or two dying questions. It's important about the Dr. R.K. Jain is here.
Sir, one question, sir. Dr. P.L.N. Kapati, sir. What are the contraindications for TAVI, sir?
Somebody else can please.
Is absence of the availability of surgeon, first and fundamental importance. So basically it is a heart team approach. So a cardiac surgeon who was also having a certification course of TAVR and all these important. And of course second, life expectancy, expected life expectancy less than 1 year. These two, and also patient with low risk. These three is fundamental, comes under the groups of contraindication.
Thank you so much, sir. I would like to invite Dr. B. Somaraju, sir, to honor Dr. Nandakishore with a shawl and present memento. Thank you so much, Dr. B. Somaraju sir and Nandakishore sir. Moving on to the next session, I would like to invite chairpersons Dr. K.M.K. Reddy, Dr. Nitin Kabra, Dr. Gokul Reddy, Dr. A. Dharmarakshak, Dr. G. Surya Prakash, as well moderators Dr. Gopi Krishna, Dr. R. Srikanth Reddy, Dr. Sanjeev Kumar Saho, Dr. Alluri Srinivas Raju, Dr. P. Shyam Sundar Reddy, and Dr. N. Ravakumari. Ma'am, please. And the topic is valvular heart disease. Yes, sir. Okay. I would like to invite Dr. B. Somaraju sir, chairperson, onto the dais. And the topic is coronary artery disease and symposium.
Invited, huh? Yes. Dr. D. Sheshagiri Rao, yes. Dr. Rajshekhar, Dr. Rammohan is there, no? Come. Why you are sitting? Dr. Shailendra Singh, you are not announcing. Sir is here only. Come. And moderators, Dr. Sharat Kumar Sahu, Dr. Hari Ram, Dr. S.P. Naidu, Dr. Santosh Kumar, Dr. Chanakya Kishore, Dr. Prakash Ajmera. Prasad Reddy, Dr. Prasad Reddy, chairperson.
Coronary artery disease and symposium. First speaker is Dr. Alluri Ravikumar on multivessel PCI in STEMI, current strategy.
Good morning, everyone. Thank you for the organizers for giving me this opportunity. So we all know primary PCI is the preferred reperfusion strategy in patients with STEMI. What is very important is these patients, they have a 30 to 50% incidence of multivessel disease. So look at these angiographic pictures. We know that the RCA is totally occluded, thrombus there, but as we can see, there are tight critical lesions in LAD and LCX also. This sort of picture always poses a dilemma because we know that this complete revascularization is the preferred strategy in these patients. But whether to do it during the index procedure or whether it should be done as a staged procedure or in a different setting, it really matters. This is another clinical scenario where the LAD is the infarct-related artery which is totally occluded, and RCA also there are borderline lesions, as you can see around 60 to 70% stenosis here. Again, the same thing, whether RCA, we know we'll do the infarct-related artery, the LAD should be done, but the RCA, what is the strategy for that? So, and this becomes very important because patients with multivessel disease, they carry worse prognosis. In patients with single vessel disease, the 1-year mortality was 3.2% as compared to patients with double vessel disease, which was 4.4%, and a 7.8% mortality in patients with triple vessel disease. So, guidelines in 2013-14, they support culprit vessel PCI only, and that was based on the historical data from the registries and observational studies, which provided conflicting evidence as to the benefit and safety of immediate complete revascularization versus culprit-only revascularization. So, these non-randomized studies and observational studies, coming to that data, in Apex AMI trial, Thoma et al., they looked at they examined the 2,201 STEMI patients with multivessel disease undergoing primary PCI, and of these, 10% of them only had a non-infarct artery PCI. And they found that the mortality was higher in this group, that is 12.5% as compared to 5.6% in patients with infarct-related artery only group. In another registry, from the data of the National Cardiovascular Data Registry, Cavender et al., they found that the mortality was high when multivessel PCI was done, and the odds were more in favor of infarct-related artery PCI only. So, basing on these non-randomized studies and observational data, their guidelines in 2014, ESC and ESCTS, they recommended that primary PCI should be limited to the culprit vessel with the exception of patients with cardiogenic shock and persistent ischemia after PCI of the supposed culprit lesion. And it's a two-way indication. And staged revascularization of non-culprit lesions should be considered in STEMI patients with multivessel disease in case of persisting ischemia within days to weeks after primary PCI. Similarly, even the AHA-ACC guidelines, they said PCI of a non-infarct related artery at the time of primary PCI in patients without hemodynamic compromise is not indicated. That's class 3. And PCI is indicated in a non-infarct artery at the time separate from primary PCI in patients who have continuous ischemia. That's a class 1 indication again. And a primary PCI is reasonable in a non-infarct artery at a time separate from primary PCI in patients with intermediate or high risk findings on non-invasive testing. These were the guidelines in 2013-2014 from the ACC and the ESC. So, but contemporary studies, they however suggested complete revascularization. So, 3 major randomized clinical trials, they have shown significant benefit of complete revascularization done during the index procedure or staged. So, coming to the first one, there is a PRAMI trial which was published in NEJM in 2013. Here 465 patients were randomized after the PCI of the infarct-related artery to either no further procedure or a preventive PCI. And the primary endpoint was death due to cardiac causes, non-fatal MI or refractory angina. And they found that there was a 65% reduction in the primary outcome. The trial was prematurely terminated because the benefit was 65% risk reduction in primary outcome. Here the table again shows that the 65% reduction in the primary outcome. And when we have a look at the Kaplan-Meier curves, what is very important is the benefit was seen within the first 6 months. The mortality benefit, no, it's not the mortality benefit, the primary outcome, the reduction of 65% was seen very early within the first 6 months after the index procedure. Coming to the next trial, there is a culprit trial which was published in JACC in 2015. Here again, 296 patients were randomized either to complete revascularization or the infarct-related artery only revascularization. And again, there was a 55% reduction in the composite primary endpoint of total mortality, recurrent MI, heart failure, or revascularization. This shows, again, the tabular form that shows the reduction of 55% in MACE events. The next important study is the Dynamic 3 Primality trial, which was published in Lancet 2015. Here 627 patients were randomized to either infarct-related artery only revascularization or a complete revascularization which was based on the FFR findings. It was an FFR-guided multivascular revascularization done 2 days after the index procedure. So they found that there was a 44% reduction in the primary endpoint, which was an all-cause death, non-fatal MI and ischemia-driven revascularization. And mainly it was, all the benefit was because of the reduction, a 69% reduction in the ischemia-driven revascularization. Again, here the Kaplan-Meier curves show that the benefit of around 44%, which was seen in the complete revascularization group. So, summarizing the 3 major randomized trials, they found that complete revascularization had a lesser primary outcome. as compared to the infarct-related artery only PCI. Whereas in a small trial that was in Prague 13, they showed no significant difference in the primary outcome between the complete revascularization group and the infarct-related artery group. And the meta-analysis, all these trials, the odds were in favor of a complete revascularization. So next comes the FFR-guided multivessel angioplasty in MI. This is the latest trial which has been published in NEJM very recently. And here again, 885 patients were randomized to either complete revascularization or infarct-related artery only treatment. And this was again an FFR, as I said, FFR-guided multivessel PCI. And they found that there was a significant reduction, a 65% reduction in the MACE events, which was death from any cause, that is cardiac, myocardial infarction, revascularization, and it's also again mainly driven by reduced subsequent revascularization. And this Kaplan-Meier curve shows that 65% reduction in the complete revascularization group as compared to the infarct-related artery group. So they concluded that the FFR-guided multivessel PCI in STEMI reduced the risk of composite cardiovascular outcome, and it was mainly driven by the decreased need for subsequent revascularization. And FFR-guided PCI has the potential to substantially decrease the number of unnecessary interventions during primary PCI. In this study, actually it was 50%. 50% of the patients did not require non-infarct related artery PCI because the FFR value was more than 0.8. Like that, in the dynamic primality trial also, they had a 30% patients who did not require non-infarct related artery PCI. So next, coming to the timing of the multivessel PCI. So advantages, we know that the same sitting, if you do the primary PCI as well as non-infarct, it may increase the myocardial salvage and the LV function, thereby increasing perfusion to the watershed areas. And it also lowers the rates of recurrent MI by stabilizing the vulnerable plaques in the other non-infarct related arteries, may reduce vascular complications by decreasing the repeated vascular punctures, and most importantly, cost effective, especially in a country like India. We find it is very cost effective because again the angioplasty repeat revascularizations cost more higher money to the patient. And the disadvantages: high contrast volume, reduce the risk of it increases the contrast-induced nephropathy and heart failure, and the high radiation dosage that is associated with it, and also operator fatigue, especially doing in the working off hours. And this shows that the staged multivessel PCI has a definitely significant lesser mortality as compared to a single multivessel PCI. And also in this, they have Hannan et al. They have showed that the 6 months mortality is 12 months mortality when the procedure was done within the, our staged after 60 days, it is definitely beneficial. So also again into the meta-analysis, again it shows that the odds are in favor of a complete revascularization as compared to the infarct-related artery PCI. And again here, staged versus single procedure multivessel PCI, the odds are in favor of a staged multivessel PCI. So there is an ongoing trial which might give important data, where the 3,900 patients are enrolled and the expected results will be in December 2018. It's a complete trial in 4 centers, in 4 countries. So basing on these randomized studies, the current data recommends, ESC recommends routine revascularization of the non-infarct artery. It should be considered in STEMI patients with multivessel disease before hospital discharge, and non-infarct artery PCI during the in-depth procedure should be considered in patients with cardiogenic shock. Just a minute. And CABG should be, this is basically it's our class 2 indications, and even the ACC AHA, they have given an update in 2015, which is no longer a class 3 indication for the non-infarct related artery. So these are some of the cases that we have done in the cardiogenic shock patients, multivessel PCI, left main, lady, same sitting, and that's again the left main is also intervened and the patient has improved from cardiogenic shock, and later on staged PCI for the RCA, and again another patient where the RCA and LFCA, LAD, L6 all are having lesions, and it was a staged procedure after the RCA PCI where left main, LAD and L6 have been done. And this FFR, another thing where the FFR did not show significance in the, you can see that the ramus lesion was tight, angiographically looks tight, but the
Can
FFR
you show that? Can you show that FFR? Can you show that FFR?
Yes.
Where did you do FFR? Which vessel?
Ramus.
That one.
Yes.
So FFR is not reliable in that lesion, in that patient, in that vessel. FFR in a small vessel distal is not to be done. That requires angioplasty, even if your FFR is negative actually.
But we...
Not at this time. Anyway, we'll talk about it.
Yes. So, coming to our data, primary PTCS in the last 2 years, 167, with multivessel being 65, that is 38.9%. During the index procedures, very few patients that we have done, 6 out of the 65, and in the staged PCI in 46 patients, that's 70%. And in another admission it is 2, deferred after FFR it was 3, that is deferred, FFR has always been done as a stage procedure, and 3 patients were referred for CABGs, and mortality was seen in 2 patients, which was mainly because when the procedure was done in the non-infarct related, in the infarct related artery and not in the non-infarct related arteries. And the current strategy, the most important thing here, patients with STEMI and multivessel disease, complete revascularization. When is it recommended? In patients with cardiogenic shock, patients with continuing myocardial ischemia, severe LV dysfunction, and patients with angiographically severe, more than 95% stenosis, especially in the LAD territory, ulcerated plaque, all these. And also when there is a doubt whether the LCX or an RCA is the culprit lesion in inferior MI setting when both have critical lesions, and a staged procedure when the patient is elderly, chronic comorbidities, CKD to prevent AKI, or it may be a staged procedure doing an FFR or non-invasive testing for the ischemia, and that is how it's, our strategy goes. Thank you very much.
Ravi Kumar, thank you very much. Very nice presentation.
Thank you.
I'm sure they will have questions related to FFR use in such lesions, and we'll come to that. And also, finally, what's your message? You only enumerated the trials. What's your message? What's your practice?
So this is what I have shown in my last slide, sir. So basically, index procedure, infarct-related artery PCI. Index procedure, infarct-related artery PCI is done, following which a complete revascularization should be done during the same sitting or not. What we practice is, if in case the patient is in a cardiogenic shock or having myocardial ischemia, continuing myocardial ischemia with no improvement in hemodynamics, we do the complete revascularization in the same sitting. And in case if the patient is not in cardiogenic shock and he is, even though the lesion is 90%, we stage it for the next, after 2 days we do the complete revascularization. And in case we think that the lesion is borderline, either we do an FFR or we do a non-invasive testing at a later stage and then get back the patient, and if it is found to be positive, we do a complete revascularization. That has been our strategy, and that's how we
Thank you.
follow.
Thank you.
Thank you.
I invite the next speaker, Dr. Sridhar Kasturi. He will speak on left main PCI in the light of recent trials.
Good morning, respected chairpersons, moderators, and dear friends. Left main coronary artery disease is associated with high morbidity and mortality because it supplies the large area of myocardium, and prevalence is almost 4 to 6% of all patients who undergo coronary angiogram, and 24% of the patients who present with acute coronary syndrome. The 2 studies which showed like almost 150 patients, the 5-year mortality 36.5% in medical treatment versus like a 16% in bypass group. Again, the mean month survival, that is 79.8 months versus 99.6%. So this study showed very clearly there is a survival benefit with the bypass group compared to medical. The third case of Andreas Grunzing's, that was a left main PCI. So this patient, after left main PCI, POBA was done and patient died 4 months later suddenly. So after that, then many interventional cardiologists, they felt that this may be very, very lethal and very high risk procedure. So Until recently, left main means almost only surgical case, but now these 4 trials throw a positive light, particularly in left main intervention side. So this is Lehman's trial, Syntax and Brodat and pre-combat. These are 4 trials, that is 2008, 2009, 2010 and 2011. The number of patients were 105 in the first group, 705 in second group, and 201 and 600. So all these trials, this is 1 year mortality rate, more in favor of PCI. These 4 trials have showed the favorable outcome with particularly the death, 1 year death compared to bypass group. And 1 year MI is also, particularly Lehman's study has shown the even myocardial infarction is less in PCI group compared to bypass group. And only the stroke incidence is more in bypass group compared to PCI group. And there is 6-fold rise in stroke in bypass group compared to PCI group. And 1 year death, MI and PCI stroke, slightly favorable PCI group compared to bypass group. But the most important observation, 1 year repeat revascularization more common in bypass group compared to PCI group. So everybody knows this Syntax score, and I don't want to go into the details. And that Syntax variables like age, gender, creatinine, and subsequently they thought that these risk factors may be contributing to the mortality. But let us see the recent trials like Excel and Nobel, these studies, whether they have shown any light, particularly on these clinical variables. This is a Syntax maze to like a 5 years left main subset. So number of patients bypass 348 patients, Axis group 357 patients. At the end of 5 years, if you see the MACE rate is almost 36% versus 31%. Again, all cause death. If you see Taxis group is slightly less and myocardial infarction slightly more, CV incidence is less in Taxis group and revascularization more in Taxis group. So MACE is also more in Taxis group compared to bypass group. So they took the Syntax score groups, sub-analysis, like if the Syntax score, low Syntax score, like a low and intermediate, they've included 0 to 32. Again, if you see the MACE rate 32.1 versus 31%. So here also death rate bypass 15% versus 7% PCI group and CVA 3.9. That means again CVA is more in bypass group and revascularization, repeat revascularization is 19, not very significant. This factor 19.8% versus 14.8%. And then Excel study came, 3,600 patients with unprotected left main. So in this, what they did, the left main, more than left main diameter, they took more than 70%. Can you get me some water? If it's between 50 and 70% is there, then they did IVUS and FFR. In this study, they clearly took the data of the left FFR and IVUS. In Excel group, the angiographic criteria more than 70%. If between 15 and 70% is there, they took the IVUS and FFR to establish that it's a significant left main disease. Again, Zines group 1300 patients, bypass group 1300 patients. Here again, if you see the Excel study results, PCI group, like primary endpoint, death, stroke and MI at 3 years, that 15.4% versus 14. That is not, there is no major significant difference we observe here. And death, MI, stroke, that is first 30 days, like that is 4.9 versus 7. That immediate mortality is slightly more in bypass group compared to PCI group. And so this study has shown, like they analyzed particularly low risk group, Syntax group, low risk group, it is alternative or sometimes it may be superior if you go with the better stent technology. Then simultaneously Nobel results were published. That is 1200 patients with unprotected left main disease, and stent was used. Their stent was used Xience, here stent used was biometrics. Why they used these stents? In syntax, taxes was used. The compared to taxes results like a paclitaxel, sirolimus, like everolimus, the second generation stents, ISR is less, event rate is less. That's the reason they have chosen biometrics as well as Xience to compare the bypass results with the PCI. The PCI, IVUS guided is must, and prepare the main, left main very properly, and at the same time left main, particularly if the LCX is very tight is there, if the really significant only do it, because two stent versus a single stent definitely changes the event, because single stent MACE event rate is much less compared to two stents, and at the same time MACE to 5 years, the distal, and it did not show whether the patient is having a distal left main or ostial left main, and at the same time if the RCS-CT will definitely impact the prognosis, and if you are doing the total revascularization is ideal, and at the same time incomplete revascularization definitely is associated with all these studies have shown very high mortality rate. So always try to do the complete revascularization, use IVUS, and at the same time plaque modification and do the complete revascularization, and syntax score definitely helps, but recent studies have not shown that much help. All these studies have not shown any, like though the syntax showed less than 22 definitely beneficial, but in noble study even below 22 also event rate is more in PCI group compared to bypass group. So I use the best test in the class when you do the left main PCI, and ideal always use the optimal pharmacotherapy, and IVUS FFR is must when you do the PCI of the left main. Really if it is significant, proceed with the procedure, and unnecessary stenting of the left main, because it involves the massive larger myocardial area, and IVUS guiding definitely helps, because the plaque modification, post-stent events, everything, because 50% reduction in the events, and choose the best technique, because the recent studies have shown DK crush stenting is more favorable compared to the T stenting and crush, so like a regular crush, and so that's the reason, and this provisional stenting always preferable. So these are the basic, some of the tips and tricks for left main. Thank you, Varna.
Questions later?
I invite the next speaker, Dr. V. Suryaprakash Rao. He will speak on CTO, when to choose antegrade and retrograde approach.
Good afternoon, the chairpersons and the delegates. I thank the organizers for giving the opportunity. CTO PCI now becoming more popular. I think V. Suryaprakash Rao is not there. Next. So most important thing is how you read the angiogram. This is very important for a beginner. You should spend time whenever you do a CTO PCI. Don't do ad hoc procedures, and read the angiogram frame by frame and see it in different angles. Maybe sometime in different times your view will change, your approach will change. If you cath lab machine has got the provision, do a rotational angio when you are planning a CTO PCI the next day. And always look for channels. Any channels are there. Unless you magnify, zoom and see, you may not find channels. And a calcification in the plane cine is very important. This indicates really calcium may play a major role in crossing. And a proximal and distal segment alignment. So this is a very familiar picture where there are some favorable points regarding the stump, a tapered stump, a blunt stump. And the side branch at the site of the lesion is always not a good sign. And a side branch and the bridging collaterals. These three things we have to see in this picture. And some of the cases, because CTO PCI always a complex PCI, you need a lot of devices and different techniques. A CT, MSCT, multi-slice CT, I usually prefer in a complex case where you see long lesions and a lot of calcium. Then these things can give you information of the length and diameter of the vessel and the degree of calcification and at any bends, and at the same time collaterals. Like this you can see in the plain angiogram, you may not be able to see. If you do a co-registration, and then you can find a track with calcification and some neo channel is seen. So a CT angio is a lot of help in a complex CTO PCI. The lesion assessment should be done in simultaneous contralateral injection. You see, the donor artery injection is given first and then this thing. So here you can find, I can play. You can find here the collaterals coming, septal collaterals filling the RCA. So the site of the collateral, septal or epicardial, length of the lesion, the calcium, the bend, distal vessel, proximal vessel, most of the information. Don't do panning during this injection, and this gives you the correct approach to this lesion. And as you know, the JCTO score plays a major role, because as the JCTO score increases, the score involves the stump involvement, the calcification, the bending and the length, and retry. Always a retry case is always, you should wait minimum 6 to 8 weeks. And if the score is more than 2, usually it is a difficult case. So then you have to have a different approach, mostly retrograde approaches in this case. But always prefer antegrade first, because the complications and the technique is relatively straightforward in this. So the likelihood of retrograde true lumen wire passage is if it is low. In most retrograde attempts, we need to connect proximal and distal true lumen. For this purpose, we need an antegrade wire always. If you put it first, you reduce the ischemia and retrograde dwell time also. When you take a retrograde, as all complex cases like osteal lesions, we need to have a retrograde in the beginning. And the good interventional collaterals will be always attractive to go retrograde. And proximal ambiguity, as I said, with the side branch coming at the lesion, and the long lesion with undefined CTO course, very long lesion, and the distal vessel is not seen properly, then antegrade is very difficult. And the distal, if there is a large bifurcation, there is always a risk of dissection and close of the side branch like a PDA, PLV. So in that case, we have to have a retrograde approach. And repeated attempts, if we try again antegrade, this failure rate is very high. And post-CABG patients also. Contrast pairing is a controversial issue. Now we can limit the contrast in both antegrade and retrograde by using the IVUS. We do most often with the IVUS usage. But most important, you should be well trained in both techniques. So here you see a tapered stump. You may see it is a tapered stump antegrade approach, simple. If you see the CT, then calcific lesions. So it's not always like standard tapering makes it easy like that. And here if you see the retrograde injection, the alignment is not there. You see the retrograde vessel coming at different angle and proximal. That means there is a bend. This is a tough case. If you straightly, you can perforate if you use a stiff wire from the antegrade. That's why the alignment of the proximal and distal segment is very important. And always look for a distal vessel. If there is no distal vessel visible by the angiogram or the CT angio, it's a difficult case. Even though it looks as a tapered stem, we think it's easy, but a distal vessel poor is a very bad prognosis. So you cannot revascularize this vessel. So a side branch occlusion less than 2 minutes away from the occlusion, a very poor predictor of success. The wire will always slip into the side branch. So in these cases, what we do, once you do some cases, we put a IVUS catheter in the side branch And on the IVUS live we puncture the cap. That is the technique what we use. So, but a side branch after the occlusion is always gives a success. This is exactly at the site of CTO, there is a small stump as a side branch. This is a very difficult antegrade approach. We have to do a IVUS guided puncture of the proximal cap in this case. But there is a stent margins. If the ISR antegrade approach very sometimes comfortable because you can see the stent margins, and if you can poke the cap in the middle of the stent, the boundaries you can visualize safely, the antegrade approach can be useful. But why you prefer retrograde in complex cases? Because the distal cap is always a soft cap, and success rate in experienced hands with dedicated centers is high. And once there is a long length tortuosity, calcification, side branch, retrograde we prefer. So, some of the cases you see, the osteal RCA here is very difficult to engage this RCA ostium with antegrade any guiding catheters. So, we usually do retrograde, and we take up the wire snared into the aorta and get into the antegrade guiding. It's a difficult cases like this. We can do only by retrograde technique, not antegrade. Like you have collaterals of epicardial collaterals, mainly septal collaterals, but 74 to 80% of the cases are done as septal collaterals. In our study, we have done almost 1643 recently presented in EuroCTO club. We have done almost 89% by septal collaterals, only 11 by the epicardial. The main problem with the epicardial collateral is the rupture of the epicardial collateral can be catastrophic. So you should prepare everything with coils and all. The axis septal collaterals are always safe. So you predict success by location of the collateral. The first septal collateral is always better if it is good, and you should see the right view to locate. A caudal view, caudal or epicaudal, is better always to see the proximal and distal connections of the collateral. Sometimes you have to use a rotational view and selective injections. Sometimes you push the support catheter in the collateral, give selective injections. The collaterals are seen as invisible to visible to maximum CC2, it is called the visible good collateral. So the direction doing from a LED septal collateral RCA is relatively easy than PD to LED. Here you can see the collaterals, the RCA CTO. Like this you have to assess. The osteal CTO, I told, we take the CT in this type of cases. The main danger of this is that you have to do a left main stenting in some of the cases while retrogradely penetrating. That is one, and you have to protect the circumflex also in osteal CTOs. And stump occlusions, as I told, RCL, I discussed already, is very difficult. Only by retrograde you have to do. And these are the cases, epicardial, large epicardial, very comfortable to cross, but be careful that the rotation during the cardiac cycle, the rupture of the collateral can come at the apex. You can see, observe that. So some of those cases, you see the attempt at CTO at different hospital, RCA, and these cases, we also tried the next time. We have done a CT, a lot of calcium is there. And there is a bend and tortuosity. The score, the CTO score is 3. So we could reach the distal cap, we cannot do it. But it's a single vessel disease. So the third attempt, we can do it by doing the retrograde. This is where the retrograde approach is very useful. Through a septal collateral, we could cross and complete the procedure. So all these cases done under IVUS guided, particularly when the wire cross into the antegrade catheter, you should always see where is the antegrade, where is the retrograde wire position before entering into the guiding catheter. So these are all having IGC2 score, we have done a retrograde procedure only. So you can reduce the procedure time, the fluoro time, the radiation in a complex case by doing retrograde. That is the advantage. These are some examples. So why not retrograde mostly? But the procedure time, fluoro time, contrast more, all these things now they changed. Now retrograde procedures getting done in experienced hands with only problem we face is the septal collateral injury, and sometimes it has to be managed conservatively or with coils, but mostly they are safe. It's not a true and true rupture. They heal over a week's period. So the cost is one factor. All the devices are costly, as you know, and ischemia to the donor artery is one problem. We have to take care of the damping problem with the catheters, and the ACT maintenance is very important. And I recommend you practice antegrade in the beginning and attempt retrograde if antegrade fails, and encounter anatomical difficulties, and most important, you gain sufficient experience after. Thank you. And I invite you all to the IVUS CTO 2018 next year here only in Hyderabad. Thank you.
Thank you, Dr. Surya Prakash. It's a nice presentation and wonderful technique. But then the issue comes when you showed a right coronary artery alone, diseased, collateralized, doing all this. There is a concept, yesterday we talked about the concept of effectiveness versus efficiency, and also doing right things right. I'm sure they will have questions. You never told us anything related to the patient's clinical profile, the socio-economic factors, related to that isolated right coronary artery, a retrograde approach. You have to explain later when they ask questions. Thank you.
Thank you. Thank you.
I invite the next speaker, Dr. Sri Raghu. He will speak on bifurcation current concepts, bifurcation PCI current concepts. I think he is not available. I now request the next speaker, Dr. K.M.K. Reddy, to the dais. He will speak on plaque modification.
Respected teachers, chairpersons, friends, my students, good morning everybody. We all know the coronary artery disease has a wide spectrum in the form of a fresh thrombotic lesion, in the form of chronic total occlusions, calcified lesions, bend lesions. There are a number of variables. So one among them is calcified lesions. Calcification varies from mild to moderate, severe, heavily calcified, where nothing is visible except calcium sometimes. So now probably my job is how to modify the plaque when there is no really way in the form of calcium. So here in the plaque modification, I want to confine myself to the rotablation, even though there are many other techniques to modify the plaque in view of the time constraints. So these are the various things that are described, but the rotablation is one of the reasonably popular things that is used for the plaque modification. So basically we know when something is elastic and elastic versus how the things are going to be cut. So when something is elastic, there will be a dimple like that. When there is an inelastic structure like a calcified vessel, probably it tends to be fragmented into a small pieces. That is the basic reason why the rotablation is used when there is an inelastic tissues like a fibrotic lesion or the calcified lesions. So this rotational atherectomy, how it is, what are the situations where it is indicated? Mostly, as I was telling, the calcified lesions when there is no way to dilate or a failure to dilate, or a difficult to dilate scenarios like a diffuse long lesion, small vessels less than 2.5 millimeter, bifurcation lesion, osteal lesions, sometimes instant wrist stenotic lesions with multiple stent layers or the jailed branches also. So for every case, to have a better success, we all know the case selection is important. It is more important in this scenario. When we are selecting a case for a rotablation, we should select very, very, very carefully. Like, what is the amount of calcium that is there? What is the distribution of calcium? And where is it? Is there any bend? And what is the size of the vessel? How to proceed? Or is there any alternative way which is a safer method when compared to this? So the mild calcium classified as less than 90 degrees, moderate calcium classified as 90 to 180 degrees arc, and it can be as a non-compliant balloon, it can be tackled with a plaque modification, either a cutting balloon or a scoring balloon or a rotablator, and the heavy calcium, always the rotablator gives some solution. So how to prepare the lesion? These are some of the pictures where give an indication or the clue that how to prepare these pictures. The lesion preparation before PTCA is very, very crucial, where it depends upon the amount of calcium that is distributed. There are strata studied to determine the rotablation and the transluminal angioplasty. As I was telling, there is two arms compared, like an aggressive arm and a routine arm in 500 patients. There are many variables described. And this is the DRAW, pre-procedure test. This is very important to go ahead with the rotablation. So drip, rotate, advancer, wire. This is something called a drip. There should be a dripping of the vessel with a saline drip from the bottom of the advancer and the catheter. Rotate, burr should be rotating, and the RPMs should be stable. And the advancer, free movement of the advancer knob, and the wiring is visible, wire should be visible, and brake should be functioning. This is very, very important. These are the instruments should be checked well before the starting the procedure. These are the various ways how it should be checked and menued prior to menuing on the patients. As we know, the guide catheter selection is very important to have a support. These are the simple things, simple coaxial alignment without support. The first JR4 is showing, and the hockey stick appearance coaxial alignment with extra support from the sinus of Valsalva. And the third is EBU, coaxial alignment with the power support from opposite wall of the aorta. So there are various noticed and understood. Other issues in the rotational atherectomy are a prophylactic temporary pacemaker is a commonly used, more so with a LCX lesion and the RCL lesion. This reluctance can be partially explained by the more hazardous management of pericardial effusion than the tamponade. Promising new platelet inhibitors have demonstrated a superior pharmacological and clinical profile than the clopidogrel and might be more effective alternative in preventing the platelet activation induced by rotational atherectomy. Some of the cases where there is a lot of calcium noticed. The another case is 64-year-old male with pulmonary fibrosis. This is this is what I was telling, when the vessel itself is not seen with a lot of calcium, probably a good case definitely for the rotablation, but it also has a difficulty. So these are the contraindications. As I was telling, it is not a smooth procedure to be done. So contraindication like occlusions not possible with the wide guide wire, a lost remaining vessel, and the severe LV dysfunction, saphenous vein grafts, angiographic thrombus pre-treatment, significant dissection at pre-treatment site, and then acute MI. There are limitations for this. There is a slow flow or no flow phenomena, which is most of the times a tough scenario, and the perforations of the vessels, CKMB release, and the wire bias and dissection, technically definitely challenging. These are the complications one should be aware, and the nightmare can be created with this. This is the something called managing the entrapment of the burr. So to prevent this, probably gentle picking motion and short turns of rotablation is required. Operators should start rotablation in eccentric and extremely calcified lesions with relatively small burrs and a highly speed of rotation. And when a small burr was employed, more slowly advancement to ablate the plaque of proximal lesion sufficiently was recommended. Operators should not exert excessive forward force during burr advancement, and it should avoid a sudden drop of their RPMs. So perforation set can be created by this. There are some trials of pre-DES era and post-DES era. I'm skipping some of the things in interest of the time. And the guidelines for rotablation, rotational atherectomy is having a class 2A indication, is reasonable for fibrotic or heavily calcified lesions that might not be crossed by a balloon catheter or adequately dilated before stent implantation. So the message is, a rotational atherectomy is a useful adjunctive device in interventional treatment of heavily calcified lesions. Optimal technique and strategy are crucial to avoid any potential complication. Properly performed rotational atherectomy followed by a DS implantation may translate into excellent long-term results and will broaden our scope of lesions we can take care of safely. Thank you.
Thank you, Dr. Reddy, for a very, you tried your best to make a good presentation out of it, but I thought it was such a highly technical procedure, should have been an angioplasty training course, or you should have been given half an hour time. Thank you.
Thank you, sir.
I invite the next speaker, Dr. Gokul Reddy. He will speak regarding OCT guided PCI.
Thank you for the opportunity given. Good morning, respected teachers and dear colleagues. First of all, greetings from our group. We are a group of 30 cardiologists and cardiac surgeons practicing in different hospitals, 6 in city, 6 in periphery. Optical OCT, actually OCT and IVUS both are equally, almost like similar tools. The difference is in OCT, in IVUS we have a small crystal which actually images the artery. In the OCT we have a small infrared focus which actually gives the signal and takes back and images. I would just try to explain what are the indications when we do in diagnostic and also procedure planning. In diagnostic, we usually see in stable CAD is similar to the IVUS. We use for a sizing lesion, sizing. The OCT is not a gold standard near the IVUS. The FFR currently is the gold standard for the sizing of lesion like stenosis percentage, but when you see for length, probably OCT and the IVUS have equal relevance. I will show this picture. ACS, the OCT is very good. It is 100% sensitive for the thrombus. It's very good when you want to identify the culprit lesion like plaque rupture, plaque erosion or dissection. In strange situation when you have two tight lesions, when you want to identify a culprit, OCT helps. The culprit lesion has a thrombus layering on the plaque. So we have two LCX and LED lesions which are both tight and you have an honest TMI with a troponically positive. When you want to know which is the culprit, probably OCT helps there. Calcium and thrombus also, OCT helps. Calcium, the IVUS is better, but thrombus, OCT is the best. Similar to the IVUS, when you want to plan a procedure, the OCT aids in the angioplasty, like lesion preparation, you can assess the calcium, the thickness, the circumferential. If you have a thick calcium and a circumferential extension, probably rotize the indication. And you can select the stent also, the size of the stent, the length of the stent, the diameter of the stent, the landing zones. OCT helps us to identify the plaque in the starting place, plaque in the ending place. The best is to avoid the plaque. And after the deployment of stent, you can see whether the stent is expanded properly, are there any malposition, or there any edge dissections. This helps in acute and the chronic long-term results. A short of the technique, because all the hospitals don't have this. The first important thing is to engage the guide very properly and coaxially. If you don't engage the guide coaxially, because it requires a lot of injection at some force into the artery, if the guide is actually pointing up or pointing down, we can have a coronary dissection. Dissections are described almost in 0.5% of the OCT procedures, so guide is very, very important to engage coaxially. And whenever you want to size the vessel, best is to go NTG, because the OCT is a bulky catheter, 2.6 French, it can lead to spasm. So probably if you don't give NTG, your sizing is inaccurate. It's important to give good injection, like in RCA we give 6 to 8 ml, in LAD we give 10 to 12 ml, and it should give over a period of 3 to 4 seconds. The OCT pullback speed is 25 millimeters per second, so the catheter length is approximately 50 millimeters, so probably it takes 2 or 3 seconds for the injection. This is the machine what we have. There is slight trick in the catheter, still there is some advancement required. Always we face difficulty in the loading of the catheter or the wire. You see the blue tip here is the edge of the catheter where we put a wire, and here is the exit port. The problem is the focus of the infrared light is exactly near the exit point. So if the wire doesn't come out here, goes into it, it can actually damage your optical lens. This is a normal picture. It's very good in delaying the intima and all media and the adventitia. This was the size I told you. I just make it fast. We have a lesion which normal size here. It goes back, slowly comes down narrow. Again, this is a normal segment. Again, this is a second lesion. So probably when we measure from the size, it is 32.3. So probably we use a 3 into 33 mm DAS. This was done as part of trial. It is not routine practice for us. This is post OCT. You can see all these studs which are fully opposed to the vessel wall. This is a case of BVS done 2 years back when we were using a lot of BVS. Now we don't use it at all. Here, this patient had an anterior MI. You can see a culprit plaque also. This small vascular. This is the area where there's a culprit lesion. Probably again I freeze it. Here you see plaque rupture. And the studs of BVS was thicker than the normal studs. They are very well opposed. In BVS, mandatory for us to check in OCT or IVUS to see that all the studs are opposed to the vessel wall, otherwise the acute issues are there. I'll give you a few examples. This was a 26-year-old lady. She actually came with a fever, chest pain and cough, admitted in medical ICU. ECG shows some non-specific, but next day morning they have T inversions, then they called for cardiology opinion. When we saw she had a mild LAD dysfunction also, LAD hypokinesia with mild dysfunction. This is the RCA injection normal. The LAD shows nostril tight disease. We did nostril stenting. The best thing for this patient was to have an IVUS, but our IVUS machine was down that day. That's the reason we thought we check OCT and see whether we can have good results. This is an OCT run. We see the stents which are well exposed, well opposed. All the studs are opposed, and this is almost like the area of left main ostium where we see the stents, and here the guide starts. The problem with the OCT is you can't imagine the ostium, because if you are supposed to engage the ostium and inject, so ostium you can't image. So whenever you are covering the ostium with the stent, probably this doesn't help. And whenever you are just short of the ostium, this helps. Second example, this again a 60-year-old male came with an anterior MI. This was the patient, left main, non-dominant circumflex, dominant large RCA. We use OCT because of sizing issue. Proximal left main appears to be 4 millimeters, 4.5, and the distal was 2.7 We checked an OCT run, this OCT injection. When you see the OCT injection, the contrast has to entirely clear the artery. If there is a blood in the visual field, the OCT doesn't, because RBs absorb all the infrared light. This is the OCT of the picture. When you see here, it's a normal segment probably here, then the lesion starts. We size here is 2.75 to 3, then again the lesion, again it's 3 millimeters, and when we go near the left main, it's almost like 4 millimeters, 4.5 millimeters. So we took a small 3 into 18 in the distal segment, we expanded, took a 4 into 28 in the proximal segment, we expanded. Then this is the result after the expansion, this is OCT done. When you see here, the stents are opposed properly in the mid and proximal portion, but when we go to the left main, almost, I'll show you, this circumflex ostium coming out. Here the stents are fully non-opposed. You see stents freely hanging in the left main. You are able to see the freely hanging stents. These kind of patients, if we don't do anything, they actually come with an acute or long-term issues. Acute stent complication is very common. We went with a 4.5 millimeter balloon and dilated the proximal port. Then this was the before the dilatation, and this was the after the pot. All the studs are opposed now. This is done good with IVUS also. This is the final result. The next example is a osteolytic critical lesion. Sometimes what happens is when we take an osteolysis, this is an acute angle, it's difficult to position sometimes. In this patient, we face a lot of difficulty. 2 minutes. We tried to position the ostium, but we couldn't. Though we thought LCX ostium is free, we actually covered the left main because we're not able to position the ostium. And this kind of patient with a plaque in the superior layer, if you position, it dissects, then it's a big problem. So we actually covered the left main. This kind of patient, when you do, always do a mandatory IVUS or a rota. Here was covered well. The initial, you see, the entire, even the distal stent is not covered. So again, the pot was done. Then we had good results. I'll show you one last case. Here is an example where probably we can have a mistake when we can cover it up. She was done last week only, a 55 lady, non-STEMI. We actually again wanted to do an osteal stenting. She had an eccentric disease, osteoproximal tight disease. We actually put this stent at the ostium. Patient took a deep breath, the stent moved proximally. Then when you see here, it's actually covering from the mid left main to the LAD. The stent was 3 into 18. So now left main appears to be 4 millimeters. So it's a big question, big problem again, because this was a design V stent, we can't expand beyond 1 millimeter. So we actually crossed the LCX. We took a balloon, did 3.5 mm balloon. Then did an IVUS. The question was whether to take a 4 millimeter balloon or just do a OCT and check. If OCT is normal, we thought we leave it alone. Luckily, OCT was normal. Here is OCT. When you see, this is the stent studs, all the stent studs. When you cover, this is the LCX ostium, fine, no dissection. Then when in the left main also, the stents are covering. There's no under-expansion. So this patient, we actually stopped at 3.5 millimeter expansion only. And we didn't take a 4 because the Zines stent, if we take a 4, they can have stent fractures and acute issues also. Sometimes bailout OCT helps. This is the final result. OCT guidance alone till date has not proven to be superior to IVUS. It's as good as IVUS. Basically, when you do OCT IVUS, you are forced to post-dilate. And the chance of restenosis is much less. Thank you.
Thank you, Dr. Gokul. It's a nice presentation. Just one, that 25-year-old girl,
yes,
was the aortitis considered?
Probably all the vasculature were normal. She actually had high triglyceride, the family history.
So there is no aortitis?
No aortitis.
The ESR was how much?
Was 18 or 19. We actually sent the ANA profile also was normal. We were surprised actually.
Thank you.
I invite the next speaker, Dr. G. Ramesh. He will speak regarding protection of microcirculation in PCI.
Good morning. So, respected chairpersons, so this is a real challenge for all our interventional cardiologists. So, slow flow is a nightmare. So, the best thing to do about slow flow is to prevent it. Really, there is no solid treatment for a slow flow. So, all of us would want to prevent it. You'll have to pardon me if I just run through my slides because of the lack of time. So, the goal of PCI would be restoration of patency of the epicardial coronary arteries with the improved tissue perfusion. So, not just the epicardial coronary artery opening, but improved tissue perfusion is our goal. So, we know this definition of successful PCI: angiographically residual stenosis of less than 20%, no major complications, and clinically patient being good. So one of the key determinants of success would be intact functional microvasculature and avoiding no reflow. Now, these are the factors which, we all know these factors. See, these are patient factors and procedural factors or lesion factors. So these are the factors which are associated with no reflow phenomena. The patient is presenting with cardiogenic shock, very long lesion lengths. Higher the age of the patient, the worse the chance of no reflow, the higher risk lesions. STEMI compared with a STEMI, patient being a smoker. If the patient initially presented with a TIMI zero flow, again the risk of no reflow is more. The patient has got very complex lesions such as bifurcation lesions, calcified lesions, where they need rotablation, or patient has presented to us late. So these are all the risk factors for no reflow. So why should we really worry about no reflow? Because of two things. One is an acute problem or early post-infarction complications and the late complications. So they are likely to develop arrhythmias, pericardial effusions, sometimes cardiac rupture with cardiac tamponade, early heart failure. Again, late probably they develop adverse remodeling and late heart failure with mortality. So we'll have to avoid developing this no reflow as far as possible. Treatment comes later. So this is an MRI picture done initially in May 2003. The picture shows a no reflow phenomena. See this. Then a year later, the picture again shows a full thickness scar with a severe LV dysfunction with a risk for sudden cardiac death. So this is the risk which is always there in no reflow. So what is really no reflow? It's basically defined as inability to reperfuse a region of myocardium under prolonged ischemia despite reopening of the IRE or the infarct-related artery. So this definition is known to all of us. If the TIMI flow is 0 to 1 in the absence of dissection, spasm, stenosis or thrombus, so this is no reflow. If the TIMI flow is TIMI 2 flow, then it's called a slow flow. So the pathogens is the most common cause. If you see the pie diagram, the largest section of the pie is for the distal thromboembolism. So the most common cause is distal thromboembolism. This generally occurs during primary PCI or rotablation. Sometimes ischemic injury can also produce no reflow along with reperfusion injuries. There might be sometimes pre-existing microvascular obstructions, and again individual susceptibilities matter, such as diabetes mellitus, hyperlipidemias, poor general condition of the patient. So what is the incidence? The general incidence is 0.6 to 2%. During primary PCI, the incidence is around 9 to 11 or 12%. SVG PCI slightly more, around 15%. But what is interesting is rotablation produces the maximum slow flow, around 15 to 16%. Again, the interesting point in this is rotablation induced no reflow or slow flow is most amenable to pharmacological therapy. So nearly 65% of these patients with rotablation induced slow flow respond to pharmacological therapy. So compared with either a primary PCI or SVG related no reflow phenomena. I'll skip this slide. So how do we treat it? So basically you can divide into pre-PCI management, during PCI management and probably post-PCI drugs. Pre-PCI you have to reduce the ischemic duration. The earlier you take a patient with primary PCI, the better it is. There is less chance of no reflow. Upstream you give good antiplatelet regimen. If required you can give GP2B3 blocker. If you're not giving newer antiplatelet agents such as Procedural or ticagrelor. Personally I generally avoid GP2B3 blockers if I am giving either ticagrelor or Procedural. High dose statin therapy, control of risk factors such as hypotension, acidosis and all these things. There is a data about ischemic preconditioning, but there is no RCTs proving it, so at the moment we'll skip it. Step 1 is analgesia, fluids, inotropes. If required, temporary pacing, IABP support. You have to exclude mechanical cause, obviously. So you exclude dissection, exclude thrombus, spasm, and check for go for a ACT check and go for. Blockers can be used if you are not giving newer antiplatelet agents, if there is a lot of thrombus burden in these patients. And vasodilator agents generally more beneficial if you give intracoronary, particularly locally delivered rather than intravenous. Acute myocardial infarction. Use a thrombosection. Huge number of trials as such. I will not go through any of these. Suffice to say that the last row, if you notice, in the 30-day mortality, there is no 30-day mortality benefit in these patients. So everything is done there. No. So there is no 30-day mortality benefit. But personally, most of us use thrombosection devices, either export catheters or thrombus catheters, particularly to prevent no reflow. But 30-day mortality might not be really showing any benefit, but all of us use these catheters. So what do the guidelines say? In 2011 and 13, they used to say that this is a class 2A indication, manual aspiration thrombectomy. Now they have degraded it to class 2B for a bailout aspiration and class 3 really for routine aspiration. So you can, routine thrombus aspiration is contraindicated rather, class 2B. So if it's a bailout aspiration, it's class 2B. So these are the catheters: thrombus aspiration, thrombectomy and distal protection. So distal protection, there is no role in using a routine coronary arteries. Distal protection, we all know the role is there in SVG PCIs. So regarding GPT3 blockers, abciximab has got the best data. The ESC guidelines tell us that abciximab is the only one which has got some data really to be used. So again, a word about defer stenting. So there is a discussion about whether we should defer stenting for these patients of primary PCA. So just read the last line as such. Compared with the immediate stenting, a deferred stenting did not reduce the nori flow. This is data about nicorandil saying that if you start nicorandil before taking the patient for PCA, we are all been using it during PCI, but before taking for PCI, you can give intravenous nicorandil. Again, post PCI, 24 hours of nicorandil will help. So not just during PCI. So if you need to do a thrombosection before you remove it. Sometimes when you are removing it, the whole thrombus again gets sucked into the distal vessel, and again there will be no reflow. So if you use a distal protection device or a spider device, do a thrombosection before removing the distal protection device. There is no role for covered stents. There is no role for GPT3 blockers in SVG interventions. There is sometimes cheese grater effect. If you are doing a stenting, you should use 1:1 stent size. You should not oversize the stent. So you might little undersize, but never oversize the stents in SVG intervention. Cheese grater effect is if you are stenting it and the thrombus burden or the plaque burden can just get displaced from the stent and go into the distal vessel. So you'll have to avoid it. Avoid post-stent manipulation as far as possible. So this is the guidelines. Distal protection device class 1 indication, GPT blockers class 3 indication not to be used, and never attempt PCA of the chronic SVG occlusions. So newer drugs, there is some trials drug called Bendavia, mitochondrial protective peptide. It might reduce ischemic reperfusion injury. There is data that dipyridamole also helps. There is data that cyclosporine also helps. And exenatide, it's a GLP-1 analog. Most of the diabetologists would be aware of it. It's IV infusion. Again, it has got some data to show that it can be helpful in slow flow. There is some data that in cardiac arrest patients, we know hypothermia helps. There is some data that hypothermia can be used in no reflow phenomena. So, this is the summary as such. So prevent no reflow. The ideal thing is to prevent it. Shorter the door to balloon time, the best it is. So optimize the blood pressures, optimize sugars. Give a good dose of statins. If required, give intracoronary dilators. Prophylactic dilators, probably intravenous also, such as nicorandil adenosine can be given. Diagnosis, consequences, we know infarct, expansion, ventricular arrhythmias. Diagnosis can be done in cath lab. You can use STEMI flow, frame count, STEMI blush grade and all these things. Treatment is giving good intracoronary dilators. So these are my take-home points. Go for early intervention if it's primary PCI, adequate antiplatelets and good dose of statins, support circulation, correct the underlying acidosis, maintain good blood pressures, selective use of thrombosection, very high thrombus burden, very early PCI, you can use thrombosection, direct stenting when appropriate, embolic protection in SVG graft PCI, vasodilators, GPT blockers, but not in SVG interventions. Thank you.
Dr. Ramesh, nice presentation. Apart from I think he almost enumerated everything. Statin use prior to occurrence of MI has some role, and also ischemic preconditioning. I think they will have questions later. We'll bring it up. Thank you.
He will speak on IVUS guided PCI, optimization of PCI.
Yeah, good morning. See, clinical roles of IVUS in PCI. We can use it for assessment of lesion severity and evaluation of plaque characteristics to guide lesion preparation, appropriate stunt sizing, and optimization of your stunt deployment and evaluation of device failure. So, and IVUS, as we know, it is a tomography of the vessel, like looking from the origin of the vessel. So, basically, it contains your catheter, and next is the intimal area, intima, and then there is media and adventitia. So Yeah, I'll go to assessment of lesion severity. So again, it is in non-LMCA disease and in LMCA disease. In a flow-limiting non-LMCA disease, there are various investigators studied about this with a functional assessment of coronary with the areas from 2.4 to 4 mm square. So the problem is here, there is a wide range in MLAs and low overall accuracy, and that's the reason IVUS cannot be used for diagnosing flow-limiting lesions in non-LMCA territory. But coming to LMCA territories, again, there is a wide variation in lumen MLAs from almost 3.9 to 8 mm square. So, but there is a good correlation when compared to non-LMCA lesions with FFR. IVUS can be used as a diagnostic modality in defining flow-limiting disease in LMCA, especially in case of distal or downstream disease, not as an isolated entity when there is no downstream disease. Still, FFR holds a good technique. And assessment of lesion characteristics to guide your plaque modification. See, here we compare the lesion with adventitia. So, if the lesion is hyperechoic when compared to adventitia, so we call it as fibrous plaque. And if the lesion is hyperechoic as well as there is attenuation beyond the lesion, it is a calcified plaque. Sometimes even you can see the reverberation artifacts. This is a calcified lesion. And the lesion is hypoechoic when compared to adventitia is a soft plaque. And lesion is hypoechoic as well as attenuated. So it is an attenuated plaque which predicts no flow in few cases. And there is an, you can see hypoechoic lesion within the plaque. This is an interplaque echolucency, maybe intraplaque hematoma. And this is a disruption in the plaque with irregular margins, plaque rupture. And these are scintillating masses floating inside the lumen, nothing but thrombi. So hyperechoic when compared to adventitia. So that's how we can differentiate, and you can plan your strategy of stunting. And sizing of the stunt. So when you take longitudinal section of the vessel, so you can decide your distal reference lumen. So distal reference lumen sizing can be done with the luminal as well as media to media sizing. It's the interest of our experience of the operator. So I take luminal sizing both distally as well as proximally. Based on that, we'll decide the diameter and also the length. So, and then we can stunt, and subsequently you can see your optimization of stunt expansion. So after post stunting, so we can see the expansion of the stunt and dissections at the distal edge and any geographical miss and apposition of the stunt and prolapse, plaque prolapse in the stunt and the hematoma. So this is a mural hematoma, which I'll go through again. So stunt expansion has been, there are various criteria for stunt expansion. So the general criteria is minimum cross-sectional area of a stunt should be more than 80% of average of proximal and distal reference lumen areas. You can take lumen as well as media to media based on the plaque percentage. And it should be more than 90% of distal reference lumen cross-sectional area. In music criteria, they use, if the vessel size, I mean overall MSA is more than 9 mm square, the same thing holds good. But if the overall absolute lumen area is less than 9 mm square, then you have to take MSA more than 90% of average or more than 100% of distal reference lumen area as a criteria, with symmetric expansion and complete apposition of stunt. So in Pravio study, they studied the stunt dimensions with the final balloon dilatation. So the minimal stunt area should be at least more than 70% of your final balloon which you used. If it is less than 70%, you can always consider redilatation or high pressure dilatation in those patients. And this is the areas with your final balloon dilatation from 2.5 to 4.5, and the 70% of the area is minimum required to end your procedure. And this is the data which showed clearly the under expansion of the stent is associated with a clear increase in revascularizations or instant stenosis. And in LMCA, it is clearly showed the minimum stent areas is very, very important in preventing MACE in 2-year follow-up. So in LMCA, the LAD ostium should be minimum 6 mm square, and polygonal confluence should be more than 7 millimeters square, and LMCA should be more than 8 mm square, and L6 ostium should be 5 mm square. This is one area where IVUS really makes difference in long-term results. Coming to malapposition, it can be of two types, acute malapposition or chronic malapposition. In acute malapposition, it is during the procedure, so where your stent is not attached to the wall. So there can be various reasons like calcification or undersized stent or finally undersized post-dilatation balloon. So but there is little evidence suggesting acute stent malapposition relation to MACE. So there is not huge evidence. And also late malapposition. So in late malapposition can be a acute stent malapposition which is continued or a complete stent apposition which may become a late malapposition. That happens because of remodeling of the vessel. Positive remodeling can cause late malapposition. And also sometimes in acute MI, where the thrombus gives you a well-apposed picture, once the thrombus is dissolved, you can make out a late malapposition. So these are the two reasons where you can make out late malapposition, but the data on late acquired stent malapposition association with MACE is again not so clear. So there are few studies which showed their association, but there are many studies which showed there is no significant association. And malapposition versus under expansion, so both can go together or may not. So sometimes stent may be well expanded, that is MSA can be more than 5 millimeters square, but still there can be an under expansion which happens in calcified lesions on the edges of the calcified lesions. And sometimes stent is under expanded, but it can be well apposed. That typically happens in negatively remodeled vessel or inadequate stent expansion in calcified or fibrocalcific lesions. Geographical miss. So longitudinal geographical miss, we say when the plaque area is more than 50% at the edges, we say it is a geographical miss, and it was clearly shown longitudinal geographical miss is associated with increased restenosis. And these are edge dissections, but usually we make out more edge dissections once you start doing IVUS. But if it is causing an MLA of less than 4 mm square, and if the edge dissection angle is more than 60 degrees, it may pose problem to the patient. But overall, edge dissections are associated with increased incidence of late ischemic events. And intramural hematoma can be a problem in post-stenting, so which can be present within the stent or proximal or distal to the stent. So which should be diagnosed, and we can treat. We can diagnose it by double circle appearance within a big circle, so something like a pseudo hematoma. And tissue prolapse is another thing which we can see, but generally it won't pose any problem unless the MLA is less than 4 mm square, which was clearly showed with the increased incidence of late ischemic events. So by IVUS, optimal stent deployment means a complete opposition and optimal expansion and no edge dissection on intramural hematoma or tissue prolapse and full lesion coverage. And in LMCA bifurcation, it is very, very useful in sizing wherever there is a size difference between LAD to LMCA for sizing stent, and also for choosing a balloon for pot, and also optimizing your bifurcation lesion. And in CTOs, it is useful in reverse cart and also in exteriorization of wire, and in wherever there is an ambiguous entry, like in this case where I am not able to make out LAD ostium. So in such cases, you can use IVUS to enter plaque and also to confirm your wire position in LAD so that you can proceed further in such cases. And in diffuse diseases, you can really plan your end of the stunt. See, wherever the plaque area is less than 50%, you can start ending your stunt there, and also you can plan your stunt sizes according to your IVUS sizes, so that you can achieve a good result. In calcified lesions, so after rotablation, you can see whether the calcium is broken or not, like in this case, and you can also decide your upsizing of bar depending on furrowing effect, and you can also see the stunt expansion post your stunting. And evaluation of device failure. So this is a classical case where in LCX there is an instant stenosis came with NSTMI. Sorry. So yeah, my IVUS picture is missing. So we did an IVUS. IVUS clearly showed under expansion of the stunt, and subsequently we just expanded with a balloon and we left the patient. So the MSA was 3 mm square, which went up to 8 mm square. Obviously, after balloon dilatation, there was no lesion. And IVUS is also useful in patients with renal failure where I have to limit contrast. This is a case, calcified lesions, needs rotablation as well as stunting. So you don't need, more than 2 injections to complete these kind of procedures with IVUS.
How much more time you need? Dr. Sarath?
Yes.
How much time more you need?
Yes. When do I use IVUS in my practice? When suboptimal stunting is detrimental, like LMCA PCI, and when angiographic information is inadequate, like assessment of intermediate LM stenosis, bifurcation stunting, CTO intervention, and diffuse and calcified disease, to understand the pathology and guide treatment, like in cases peristunt, new lesion or haziness, acute and late stunt failure. And when contrast is an issue, again IVUS really helps. And more complex the lesion, more the benefit from IVUS. Thank you.
Dr. Sarath, thank you for the presentation. I think questions will be raised on, with the government reforms on stents, how often are you using IVUS now? And secondly, prior to these reforms, how much were you using? And what was the difference you noticed for the patient outcomes between earlier and now in your practice, both patient outcomes as well as financial? You have to answer that later. Thank you.
Yes.
Now I invite Dr. Pramod Kumar. He will speak regarding FFR guided PCI, recent evidence-based approach. After this talk, we will have brief discussion and question answer session. I request all the speakers to be available.
Respected chairpersons, moderators, my dear colleagues. The topic I'm going to speak is FFR, recent evidence-based approach. So as you know, FFR is the gold standard for diagnosing the myocardial ischemia, and it is easily obtainable by passing a pressure wire, the ratio of distal coronary pressure to the aortic pressure. So it is known to be very significant if it is less than 0.8, and it is not significant, it is more than 0.8. Of course, the earlier deferred trial has used a cutoff of 0.75, but currently the accepted cutoff is 0.80. Now, the utility of FFR is in several indications. Firstly, to assess the physiological significance of visually estimated lesions, and to reclassify the lesions for intervention, it is also useful, and to evaluate the jailed side branches during the bifurcation procedures, and to guide revascularization strategy in multivessel disease, and to assess lesion significance in acute coronary syndrome, and to guide PCI of non-culprit coronary vessels during the primary PTCS. Now, I would like to discuss the following things because they are the current evidence, and I think they are going to change some of the concepts. First is the defer 15 years follow-up, and second is the importance of post-stent FFR. There is a publication on that. And FFR in non-STEMI, that is the famous STEMI trial, and FFR in non-culprit PCI during the STEMI. There are 2 trials that are available. One is Dynamic 3 Primality, and also Compare Acute. Now, the defer study, as you remember, is one of the earliest trials of the FFR, which looked at single vessel disease in intermediate lesions. and 325 patients with stable angina were enrolled in this trial. So these people, they were randomized into deferral or performance, and all the patients underwent the FFR. The cutoff that was used was 0.75. So we are interested in looking at the people who had more than 0.75, who went on to deferral group, and also people had more than 0.75 and underwent a PTCA, that is a performance group. So these two form the comparative groups for our interest. Of course, the people who had less than 0.75, they come under the reference group. So it is very interesting that though this is a small number, 92% of the patients had a follow-up at 15 years. And if you can see this publication by Zimmerman in 2015, you can see that in the deferral group, the patients with MI was only 2.2% as compared to in the performance group 10%, which was statistically significant. So it showed that after 15 years follow-up, the rate of death was not significant between the three groups, the referral or the deferred group or the performance group, but the rate of myocardial infarction was significantly lower in the defer group, 2.2%, compared with the performance group, 10%. So that concluded that among patients with stable chest pain, coronary stenosis that are not responsible for inducing ischemia, as indicated by an FFR of more than 0.75, have an excellent outcome when treated medically, even after 15 years of follow-up. And performing PCI of such functionally non-significant stenosis has no benefit compared with medical treatment. So therefore, this is a very long-lasting statement that it also indicates there is no late catch-up in these people, and deferral can be safely done in the people who have a non-significant FFR. Now, the second I would like to talk about is the FFR post-stent implantation. There is some trials are there which have looked at the impact of post-stenting FFR. So as you know, normally the FFR should be 1, and if it is less, as we discussed, the cutoff of 0.80, it is before the procedure. But post-procedure, what is the cutoff? There are several publications which have different figures, but the latest that is published by Lee et al. From the analysis of DK Crush 7, they have shown by ROC curves, they computed and found a cutoff of 0.88. So that is the cutoff they have used, and it's strongly correlated with the target vessel failure. So patients who had a post-procedure FFR of more than 0.88, they had a less target vessel failure compared to patients with a post-procedure FFR of less than 0.88. 6.1 versus 12.3, that is a significant value. So cardiac death at 3 years was also lower in the group with a higher post-procedure FFR. So I think it is easy for us because anyway we are doing the FFR. Most of us after completing the FFR on the same wire we go and stent. So it is easy to again check the FFR value after stenting. So this is one of the new evidence that is available. Now thirdly, I would discuss about the non-STEMI. So previously we were using only FFR in the stable coronary patients, but there are trials now which support the use of FFR in the non-STEMI and also STEMI. So this is called famous NSTEMI, published from the British group. The management and outcomes of NSTEMI patients randomly assigned to FFR guided management or angiography guided standard care. So this trial, about 350 patients were randomized into two groups. One group, the FFR was performed and it was disclosed to the operator. In the other group, comprising about 174 patients, FFR was done, but it was shielded from the operator's vision, and it was not disclosed to the operator. So subsequently, the patients, based on the operator decision, the people who had a significant FFR and known to be disclosed to the operator, they went ahead and revascularized those patients. If the FFR was not significant, they have randomized them to medical therapy. And subsequently, for the people who were blinded to the FFR, they were handed over the FFR values and asked to re-adjudicate what would they advise to their patients. So interestingly here, there is a lot of change in the decisions. The initial assessment was different, and after the FFR results were known, the final decision was different. So if you can see here, the optimal medical treatment initially was advised only in 18 patients. Subsequently, when they came to know the FFR values, a lot of patients came into the optimal medical therapy group. So FFR values have impacted change in almost 1/5 of the patients. So the decisions are varied, by knowing the FFR results. So FFR disclosure resulted in a change in the treatment between medical therapy, PCI or CABG in almost 20% of the patients. At 12 months, revascularization remained lower in the FFR guided group, 16 versus 20%, almost significant, 0.54 was the value here. So we all know that if you go by FFR, the incidence of revascularization, repeat revascularization is definitely less. Now lastly, we are going to talk about the STEMI. The two trials, Ravi Kumar in the beginning has already discussed these two trials, Dynamic 3 Primality and also the Compare ACS. So the Dynamic 3, it has randomized people to IRA PC only, that is infarct-related PCA only, and the other group, they have done a complete revascularization. 2 days later, they assessed the FFR and subsequently did the non-culprit vessels, about 314 patients. So the primary endpoint was shown here, which was a composite of all-cause mortality, non-fatal MI, and ischemia-driven revascularization of the non-IRA lesions. You can see here it was lower in the people who had a complete revascularization as compared to the ones who had incomplete revascularization, that is the culprit vessel only. And there is a sub-analysis which is interesting, published recently. This is a Dynamic 3 Primality sub-analysis. Here you can see that people who had a FFR guided complete revascularization had lower event rates as compared to the people who had infarct-related artery only. They subdivided them into 2 vessel, 3 vessel, and also depending on the proximal or distal lesions, and also on the lesion severity, whether it is 90% or less. So here there is some important things here. You can see here people who had a more than 90% plus FFR guidance, they did better as compared to people who had a less than 90% and IRA alone. So usually if you look at the data, if somebody has a lesion of 90%, it closely correlates with a significant FFR value. So if you are not using the FFR, I think when we are confronted with the problem of opening the non-culprit arteries, if it is proximal and more than 90%, I think we should consider extrapolating this data to open that arteries. Now, lastly, the Compare Acute trial is a similar one. 295 patients were included in the IRA group, and the other one, intention to treat 590 people. So here again, FFR guided complete revascularization resulted in a lower 7.8% compared to the infarct-related artery only revascularization 20%. So again, it underscores the value of FFR in reducing the recurrent revascularizations. So this study concluded that FFR guided complete revascularization of the non-infarcted artery in the acute phase of primary PCI significantly reduced the risk of composite MACE outcome as compared with the strategy of treatment of IRA only. So this reduction was mainly driven by the decreased need for subsequent revascularizations. So my take-home messages, my dear colleagues, FFR is a validated method of lesion assessment, not only in stable CAD, but also in acute coronary syndromes, both non-STEMI and also STEMI. And long-term safety of deferral of PCI in lesions with FFR more than 0.8 is well established, and approximately 20% of the patients may get a revised decisions regarding the method of revascularization if we perform FFR. And post-DS FFR has also got some importance and prognostic value to assess the target vessel failure. Thank you very much for your attention.
Thank you, Pramod. Nice presentation. Did you come across any situation where, you'll answer it later, but say asymptomatic patient, negative stress stadium, stress perfusion imaging, but FFR is positive. How do you explain those things? And I'm sure some of them will want to ask those questions.
Now we can open the session for question answers. So if there are any questions. No, already Dr. Somaraju has asked so many questions. Please answer them. So we can start. Yeah, with Ravi Kumar.
Sir, you are mentioning about the FFR in ramus lesion. I feel when the ramus size of the vessel is quite good and probably mid location, I think FFR carries a value in that.
See,
and also in a
it's not only the size of the vessel. That lesion, most of us felt it is tight lesion.
Yes, angiography.
In a tight lesion, when
I was
you put
surprised.
a wire, you may sometimes close it. That's not a nice thing to do in acute MI. Secondly, I wanted to also ask you, was this patient in shock?
No, this patient was not in cardiac. The first patient which I saw, which I showed you.
What was the LV EDP in this patient with multivessel disease?
No, basically patient came with an inferior MI where the RCA was totally occluded. Just opened up the RCA and put a stent there. And wanted
I'll help you.
I just want to finish it.
I'll help you here. See, in a patient with acute MI, LV EDP is usually elevated. With a high LV EDP, this FFR is not reliable.
Yeah, but of late, these trials, if you look, and it's been after 48 hours, once we know that the LVDP is going to come down, definitely it has a role, no doubt about it. Only when during the acute setting, when you're doing it in the primary PCI setting, probably I definitely agree with you. But this patient, LAD was there, another 50 to 60% lesion. So we did FFR for the LAD as well as the ramus there. And main purpose of doing FFR was for the LAD, and LAD was not significant. But surprisingly, ramus we thought it will be significant, but it came out insignificant.
Don't rely upon
and
FFR.
TMT done at 6 months.
Say it's something like this. TMT won't help you here. Should not do FFR for lesions which are already tight. You may end up closing them. That is not a nice thing to do in acute MI. My message to people around this.
Sir, my question is to Dr. Pramod Kumar. Recently we have one patient, that patient diabetic duration 20 years. He always complaining of weakness and LAD mid segmentum borderline disease. So we did FFR for that patient, and FFR is around 0.85. And TMT is a 4 mm ST depressions. Can I do stenting or not for that patient?
If you have demonstrated ischemia either by treadmill or by thallium or by FFR, I think definitely there is an indication to go ahead and stent that vessel. And always in the FFR context, it is mentioned that you have to also use your clinical judgment. So always that is more important. You have to know the patient data presentation, the angiographic profile, and FFR is going to supplement that.
Is this patient symptomatic, Dr. Rama?
Yes, sir. He is symptomatic and duration of diabetes 20 years.
No, angina is there?
He is always telling weakness.
He has angina?
No angina, sir. He always tells weakness.
Okay. Weakness is non-specific. Then, is there a resting electrocardiogram is normal, no LVH?
We did ECG showing ST depressions 4, then more ST depressions.
No, in resting electrocardiogram is normal?
Resting ECG is normal, sir.
No LVH?
No, sir. But we did stenting for that patient, and it is not yielded, sir, very calcified. We have to do again NC balloon dilatation.
See, if you have doubt about severity of lesion and treadmill is positive in a symptomatic person, I would say do a alternative perfusion imaging, stress perfusion imaging you should do. And you would have avoided this difficult angioplasty in case.
Sir, we are running a short time actually. Sorry, sir.
Well, that makes the end of the session, and I would like to thank the chairpersons, Dr. Somraj Garu and Dr. Shailendra Singh, and also Dr. Ram Mohan, and also to the moderators and also the speakers. Thank you so much. And now we are moving to the next session, which is congenital heart diseases, and for this we would like to invite the chairpersons, Dr. P. Seshagir Rao, Dr. Manoj K. Agarwal, Dr. Nitin Kabra, Dr. Prasad Reddy, and also Dr. PLN Kanparthi to come onto the stage, and also the moderators, Dr. Sadananda Reddy. Yeah.
Dr. Balbir Singh is here, sir, just concerned to be the chairperson for the session, sir. The moderators are Sadananda Reddy, Dr. Sridevi, Dr. Pavan Poddar, Dr. Dinesh, Dr. Siddharth, and myself.
We would like to request the speaker Balbir Singh, Dr. Balbir Singh, to also come. Well, sorry for the inconvenience. That's my mistake, I'm sorry. Right now we want the speaker, Dr. K. Nageshwar Rao Garu, to speak about this congenital heart disease.
Sir, excuse me. Dr. Haidar Khan Garu, please chair the session, sir. Thank you.
Not only in, and he is a good international pediatric cardiologist, and he is a very good teacher and researcher also. And I think he has got many procedures also, he has got patented many procedures in pediatric cardiology. And it's a pride that Nageshwar belongs to our place, and it is a pride to introduce him, Dr. Nageshwar. Go ahead with.
Thank you very much, sir, for your kind introduction. I thank the organizers, Dr. Sridhar Kasturi, for this event, and which is going very, very well. So I am going to stick on to very, very recent advances in interventional management of congenital heart disease. My colleague will be speaking on structural interventions in adults where physiological abnormalities are so many. The challenges are essentially difficult in anatomy. Each child has got different anatomy. The complexity of the lesion, unstable hemodynamics in neonates and critical cases, small children, lack of customized equipment. Every child needs a different equipment. And we need to actually have different things. What is possible? Development of new technique, a new equipment, or existing equipment which is there and refined to that particular case scenario, and better understanding with the recent advances like rotational angio, 3D echo, 3D printing, and understanding the hemodynamics during procedures will make the patient better and your intervention is going to be smooth. The areas where the developments and innovations happened in the last 1 decade or so, access, equipment, and lot of newer devices, newer techniques, and new indications are coming day by day. The vascular axis, if you look at, you have transcarotid apart from conventional, axillary, hepatic, and other things. We adopted in neonates this particular approach, transcarotid approach for the ductus arteriosus stenting, and we could do successfully in the beginning. Then later on we found that this hybrid technique is a bit cumbersome, opening the carotid artery and then again scar and other things. So later on we adapted to actually percutaneous transcarotid approach in PDA stenting in most of the cases at this point of time. So it's very simple, and actually you can see the ductus arteriosus is very, very vertical in these babies. So what we do is we straight away go with the sheath and position the wire, and then you can actually do that. Some of the cases you have significant branch PS stenosis, where what we do, like you do bifurcation stenting, we again recross with the 2 wires and then do dilatation of the struts of that particular ipsilateral stenosis. So it is reasonably safe, and then there is a publication last year in the Circulation showed that percutaneous carotid is really safe and no complications. So that's why we adopted. Certain cases where IVC is not there, neonatal surgery is already done, where you can do transhepatic approach. In this particular case, we adopted transhepatic approach and deployed the AST devices successfully in this child, where you can see that it's a fossa ovalis defect. Now we do transhepatic in certain indications like Fontan fenestration. Going from femoral vein and perforating the Gore-Tex graft is difficult. Sometimes we do this procedure in lateral tunnel Fontan especially. And while coming back, generally we close that with the track will be closed with the coils. So transapical is coming more and more popular with the TAVI and also paravalvular leaks, which one of my colleague has done some 4 cases. This is a critical case of aortic stenosis. There was, baby was shocked and no axis. Then we had to do transapical procedure. Various equipment, existing hardware we don't explore, especially coronary CTO wires, coronary catheters, micro catheters we use often, and then we do the procedures successfully. This is the pulmonary atresia intact septum, where conventional method is to do radiofrequency ablation. Here we used CTO wire and perforated, and we actually published in one of the major journal around 26 cases. Now we recently adopted and modified our own. This is a case of pulmonary atresia intact septum with tricuspid stenosis. Our catheter did not go. Then we had to put a micro catheter and release the cautery there. So when we put the cautery, the wire just pierced the pulmonary wall. Then you can snare it. This is a 3 days baby, where then subsequently the procedure was very much successful, doing the balloon dilatation and other things. So these are all some of the newer innovations we do after gaining a lot of experience and seeing the problems technicality in these babies. But sometimes it's very difficult. Surgeon cannot reach there, cardiologist cannot do interventions, where we do actually hybrid methods, especially in pulmonary atresia intact septum, where wall-to-wall heart is there, 90% CTR and all, it is very difficult, or intraoperative pulmonary stenting. This is a case of pulmonary atresia intact septum where severe TR, wall-to-wall heart, we had to actually do hybrid pulmonary valvotomy on table. So here, some of the cases we refine the technique and do. This is a case of a neonate of 26 days with refractory heart failure due to massive hepatic AVM. You can see the CT angio, and we had to use mother and child technique to do targeted delivery of coils at various levels. Otherwise, baby will develop a hepatic necrosis. So newer devices which are available at this moment are ADO2 additional size, AVP4 fenestrated devices, and so many valves are there. These are all various devices which are commercially available and experimental basis which are available. This is another case example of a baby on ventilator from Guntur, 2.1 kilogram baby with refractory heart failure. We had to put a ADO2 AS here, you can see, and successfully closed because baby was not fit for the procedure at all. So additionally, like 1.6 kilograms with complex heart disease, this baby was having intracardiac TAPVR with large ductus in a right aortic arch situation. So we had to actually intervene and close, and the baby became stable, and baby gained weight of 3.2 kilogram. Sometimes you don't have solutions of a large ductus where you can use newer devices like long shank Acute devices are available which can be used easily. This is a case of pulmonary atresia VST where multiple collaterals are there. There is a native pulmonary arteries are very good actually. So surgeon actually felt that he can do the intracardiac repair. Then we had to close with multiple plugs here. You can see the post procedure. There is absolutely no collaterals at all, and the child underwent a successful collateral closures using the AVP4, which can go easily through 4 French diagnostic catheter. That is the beauty of the newer device. So this is the fenestrated Acute device. You can see the fenestration. You can use in elderly where heart failure is there. You want to pop off the left atrium. These are the devices which are going to be very, very useful. And we successfully used in couple of cases. My colleague is going to show that. This is a Lee coil actually from Clean University. Professor Lee actually developed this in case of subpulmonic VST where prolapse with no AR is there. It happened that we did for 3 cases in our center, and which is not available at this moment in our country, but it's a very, very good, and it supports the valve. This is the newer multifunctional occluder called Konar MF, developed by myself and Jack, an engineer from LifeTech Scientific Co. And we actually, it is under patency is applied, and CE mark is getting soon next month. And this can be used in various indications are there. Coronary, this is one case example of coronary AV fistula. We used it retrogradely, antegradely, VST, So many indications are there. It is going to be versatile device in closing lot of congenital abnormalities. Whereas the post-operative free pulmonary regurgitation can be handled with transcatheter pulmonary valve. This is the one of the patient underwent surgery long time back. She is an athlete, and then right ventricle dysfunction started recently and class 2 dyspnea, and we had to do 3D printing with the help of a Belgium group materialized, and we published it actually this year. You can see the 3D printing, and then we actually opted for the device. You can see that percutaneous pulmonary valve being deployed successfully in a large heart 40 millimeters device. So many other indications like retrograde, it is no more newer, even though we published it 6 years back, and all over the world people use this kind of technique. This is another technique which I would like to tell. We actually introduced this in infants, muscular VST, going from the foramen ovale and crossing the VST and then deploying the device is going to be very, very smooth because you are not puncturing the artery anywhere. So transcatheter parts is becoming popular in case of idiopathic pulmonary hypertension, but still results are not to be unknown actually. That's why it's not being popularized in our country, at least at this particular point of time. Fontan fenestrations, one of my friend Dr. Shivakumar did from the jugular, and now it is becoming popular, and there are several case reports are coming up with this because Gore-Tex patch perforation is going to be very, very difficult. So other indications coming, RVOT stenting came and then little bit vanished now because early corrections are very possible. So other important conditions picked up by our group only recently called Abernathy malformation in the last 3 years, and we have successfully closed in close to 14 cases. This is the portohepatic systemic connection leading to the pulmonary hypertension or pulmonary AV malformation, and we occlude the communication and checked various hemodynamics and successfully closed that. So in summary, the newer developments in interventions of congenital heart defects are essential to improve the better outcome. Innovations in device and new device made the procedures somewhat more effective and safe, and if you compare 2000 to 2017, there is a tremendous improvement. More newer indications of palliative, hybrid and extracardiac interventions are really adding to the list every day. Thank you very much for your attention.
Thank you, Dr. Nageswara, for your excellent presentation. I don't think many of us, any of us can do this procedures. I don't think anybody can do this type of procedures are here.
Thank you, sir.
Dr. Nageswara, what is the largest size of this ADO2 available now?
ADO2 6-4 is available.
6
sir.
only,
6-4 is the 6 is the diameter, 4 is the length. 6 also is available.
Yeah, because recently we used one, we did with ADO2 one USD retrograde approach. That's when. So we wanted, we deployed a 5x6 device in that patient.
Good morning, everybody. I thank CSI organizer for giving Care Hospital or opportunity to present from newborn, fetus to adult. So after marathon of infants and pediatric, we'll move on to the congenital heart defects, challenges and intervention in adults. I'm sure many of our adult colleagues are handling this kind of cases, but we'll see that how they are different from routine managements. So as we all know that they have birth defect which continues to be there and it progresses till adulthood. So there has to be physiological changes, anatomical changes, which makes us more challenging to do procedure during adult life. So they may develop ventricular dysfunction, there might be high pulmonary artery pressure or left ventricular dysfunction. There will be prolonged volume overload condition like tetralogy of Fallot's, which has been operated in infancy leading to free pulmonary regurgitation. Or pregnancy can give a problem during coarctation of aorta, and they may need palliative or definitive procedure to have normal pregnancy. So these are all the complications that we face by the patients who are having the defects from the birth and they grow up to the adulthood. So as I said, there might be comorbidities due to there might be systemic hypertension, coronary artery disease, or there can be various anatomical and physiological challenges which makes these cases very much significantly important. So this is, I'll go by with the case example, and at the end we'll come to know that how they are different. So this is a 30-year-old gentleman who has been presented with us with the hypertension and diagnosed case of coarctation of aorta. So as we can see that the coarct segment is completely interrupted. There is no continuity from the thoracic aorta proximal to the distal segment. And that same thing was confirmed in the CT scan. So what should we do? Should we do surgery or stent, or how we are going to cross this completely interrupted segment? And since subclavian was coming very close to the obstructed area, are we going to jail the subclavian artery? And how we are going to seal the dilated area, suppose we dilate that the coarct area. So these are all the questions. So definitely surgery is not an option in the adult cases because there are very high chances of paraplegia because of the steel of the collaterals like we have seen in this case. So what we did is, we passed two catheters, one from the radial artery and one from the femoral artery, and tried to poke that with the various wire from the antegrade and retrograde method. It was not possible to poke it from the antegrade area, so retrogradely the thermo wire hardened was passed from the MPA catheter, and then it was snared in from the radial artery. After snaring, the MPA was also snared, and then later on it was exchanged with the Amplatzer wire. Now this is not the end of the story. We have not completed the case, because Amplatzer wire crossing doesn't mean that we will be successfully passing this larger sheath which is going to deploy the stent. So we are catching and holding the Amplatzer wire from the radial artery and giving a traction by a snare at the radial end, and then we could advance this sheath, which is 14 French sheath, across this segment. Now, as I discussed that there was a concern that are we going to jail the subclavian artery. So we have crossed the sheath and parked one wire into the subclavian artery and one across the right subclavian artery and one across the left subclavian artery, and we are going to inflate the stent so that the covered stent is not going to occlude the left subclavian artery. So how we are going to do this? We took two balloons which are 10 into 40 Cook advance balloon. Over that covered CP stent was mounted of 39 mm of size, and after mounting it was taken. Then sheath was partially removed. Usually we completely undo the sheath and then we inflate the stent, but here to have a proper positioning of the stent, we partially remove the sheath and then we have inflated the stent so that the subclavian flow is also established and it's not going to be occluded by the covered stent. Later on the sheath was completely removed and stent was inflated. And at last exit angio, we can see that there is very nice flow. We have to use the covered stent in this situation because otherwise there is going to be leak and perforation of the aorta because it was completely interrupted segment. Now let us see the second case. He is an adult with hypertension with history of anterior wall MI. He had large X-ray suggestive of similar findings that there is a cardiomegaly, and ECG of same suggestive of inferior wall MR and right bundle branch block. He had large ostium secundum ASD along with the severe left ventricular diastolic dysfunction and LV apical aneurysm. So if we close this ASD, they are going to develop the flash pulmonary edema, and we have to close this ASD because the patient is in right heart failure. So we are walking on a very narrow rope. So what are the options that we have? Again, surgery. Very high risk because patient is having left ventricular dysfunction. So here is his cath data which was going with his clinical finding of QPQS 5:1. So what should we do? So we decided, since the ASD was deviceable, we decided that we have to create a fenestration in that defect in that ASD so that it's going to be an egress for left atrium. So we have taken a 11 French dilator and close to the central part of the screw, the perforation was made and it was later dilated with the 8 millimeters of balloon. So after perforation was, as we can see that it is well established, the device was deployed by the pulmonary vein technique because it was a large defect. And it was confirmed by wiggling maneuver that it's in the stable position, and we can see that the fenestration is well functioning. It was giving a gradient of 10 millimeters of mercury. That means there is adequate egress for the left atrium. So even the literature has showed that wherever there is a pulmonary artery hypertension borderline, maybe mild to moderate pulmonary artery pressures with left to right shunt, with QPQs of 2:1, or there is a left ventricular diastolic dysfunction, the fenestration of atrial septal defect is visible, and they stay for around 3 to 6 months of time. Now this is our next case, who is a young lady who is married, and incidental detection of hypertension during pre-pregnancy checkup, and she had this middle aortic syndrome with severe obstruction, discrete lesion at the abdominal aorta. We can see there is a significant pressure difference by radial and femoral pressures. So again, it was very difficult to cross this lesion from the retrograde method that we routinely do from femoral artery technique. So we snared that from antegradally. And after snaring, when we were trying to pass the 14 French sheath, she went into severe kind of shock. We can see that her pressures were around 40. So we realized that there is a dissection of the left femoral artery. We have taken left femoral artery because the right femoral artery was occluded due to the disease process, that is Takayuki-arthritis. So later on, we are in a stiff condition because there is one side there is a coarctation and the artery is dissected. So we have to rescue her with 8x100 self-expansive peripheral stent. And since there was no femoral access, we have to relieve this middle aorta, we have to go ahead with the carotid access. This is first time described probably in the country because nobody has done this carotid access for the coarctation. It is usually done for the crossing, but sheath was never taken. So since we had a fear of this disease process which may cause a problem to the, which can cause dissection to the even carotid artery, so we have done the open stenting. We opened the carotid artery and stent was deployed through carotid method. Again, it was a covered stent to avoid dissection of aorta. And she was doing well later on. Now this is another lady who has undergone a prosthetic valve at mitral location around 10 years back, and she had severe paravalvular leak and she was in congestive cardiac failure. We can see that the prosthetic valve is in position and there is a severe leak. So this leak was actually a crescent shape, was 14 millimeters and 7 millimeters in dia. So we don't have any ideal device which is going to completely close this. So we thought that we have to go ahead with the two devices. Same thing has been confirmed by intraoperative TE. So after doing interatrial puncture and snaring the catheter by retrograde method, the first device was deployed, that is 14 millimeter Amplatzer muscular device. We thought that this might be adequate, but T showed that there is severe leak through the peri-device area. So as we thought that we may need another device, we again crossed the lesion and we have confirmed that in the echocardiogram. Obviously angiograms are of no use in this situation and we have to confirm every time position of the catheter and the wire by echocardiogram. The another device which is AVP2, which is a triple disc device anchored to the previous muscular device, and it was deployed, leading to no mitral regurgitation in the final echocardiogram. So we can see that there is no mitral regurgitation. This is muscular device and this is AVP2. This is a case who has presented with again a heart failure after pregnancy, immediate postpartum period. She was a young lady and she had continuous murmur. So this is an angiogram at the aortic root level which is showing that there is a massive dilatation of circumflex artery and there is a filling of left atrium and left ventricle. So this was actually a coronary AV fistula to left atrium, which is extremely rare condition. So same thing was closed by vascular plug of 20, LifeTech vascular plug, and she did fantastically well, like her heart failure symptoms were improved. The last case, a large ASD with extremely deficient rims. So again, a closing large ASD, there is a possibility of collapse, a prolapse of the LA disc into the left atrium and difficult to position all these devices. So we have done balloon assisted technique where bilateral pulmonary veins were accessed and device was deployed with the help of pulmonary vein technique. So I thank you all with the take-home message that the physiology is very important to be understood because it is going to change from congenital, neonatal to the adulthood, and we have to plan this procedure much in advance to avoid complications. Thank you all for your patience.
Thank you, Dr. Sweta, for showing the excellent cases in adult patients. In the one patient, this with middle aortic syndrome, why did you not consider the axillary approach instead of this carotid approach? Axillary.
We took axillary artery diameter that was 4.5 millimeters. So that was more than the 14 French sheath.
So, would you think that the long-term prognosis of these large ASD closed with such bulky devices would be as good as the simple surgeries which can be done in these patients? So you have to, before we advise, because if you take a large bulky, there are some reports of impinging into the aorta and causing some erosions into the aorta. So in case of when you are closing defects which have very poor rims and putting very bulky devices, one has to also understand the long-term implications, and we are just avoiding a simple surgery in these patients.
Yeah, I agree with your concern, but the reports have shown that if we undersize the device, it has chances of erosion, not actually the oversizing device. And secondly, there will be rims. Without absent rims, device placement is completely impossible. So there will be rims which are going to be deficient. So up to 40 millimeters, the FDA approval is there. Beyond that, I agree with you that it's really doubtful condition.
Whenever you're using a balloon assistance for placement of the ASD devices, how are the long-term results, what is the data on that?
Sorry, I didn't get you last time.
Last case you did a balloon assisted ASD device closure.
Yes.
In this, what is the long-term data? Do they do well later also?
Yeah, so what we have seen in our cases that there will be immediate improvement in the form of symptomatic status, but definitely chances of arrhythmias are not going to come down. Once we close any atrial septal defect beyond 25 years, so arrhythmia chances are not going to come down, but there will be significant improvement in the symptomatic status. But if we consider surgery versus device closure, then definitely one is the patient choice. We explain them that what we are going to do, and if they opt for device, then we go with that. And second thing is the scar related problems and pericardial effusion, all these are the other issues. And there are studies between surgical and device, not with the larger devices, but otherwise also if we close a device, there will be more chances that right ventricular remodeling is going to happen faster than the surgical closure.
My question was, if you use a balloon assistance, does the outcomes change when you don't use it? There is the long-term outcomes, do they change in any way? Because you're using it in large, very large defects only.
Very large defect balloon, without balloon assisted is a difficult method.
Thank you, Dr. Shweta.
Thank you so much.
Request Dr. Girish to talk about surgery for very early, is it too early?
Good morning. At the outset, I would like to thank the Telangana chapter of CSI to invite me for this session. It's a wonderful session, and I'm thankful to all the organizers, Dr. Sridhar Kasturi, Dr. Sridhar Pediatric, Dr. Nagesh Rao for having me here. I'm a senior pediatric cardiac surgeon at Apollo Hospital since 2009. Basically trained at Philadelphia and Amrita. The topic I have chosen today is how early is too early. Earlier, things were like you wait for changes to manifest, the patient earned the surgery, and then later on went to say wait for 10 kgs of weight. And then now it's like never too early. You can do surgery as early as possible. Primary repair is the best because the child has a very normal postoperative growth rather than this course is a little stormy but better tolerated afterwards. There has been a significant paradigm shift in the treatment of congenital heart disease. To go back to history, cardiac surgery itself started off with Gross's PDA ligation in 1938. Then bladder toxic shunt was in 1945, which sort of paved the way for treating cyanotic heart disease. I'll just go back a little bit into my personal experience. When I was doing my medical training, our pediatric professors used to ask us about the management of child with spell. They would talk about oxygen, sedation, calm the patient down, knee chest position, everything. But when I was studying, at least, surgery was never mentioned. Probably it might be the lack of access of quality surgery, but the center where I did my training was in the state of Kerala, where the only center that was doing cardiac surgery was in Sri Chitra Institute. I'll just go to a case which I had an opportunity to get involved in, and I thought I'll go on from there. We had a baby, we had a fetus which was diagnosed with Epstein anomaly at 28 weeks. This is the first time the mother was seen. And the mother had initially had mechanical MVR in her early adulthood, and she was on warfarin. And the baby had a fetal warfarin syndrome. It was advised, she was advised close monitoring, but as usual, she never came back for follow-up, and at 32 weeks, she came for a regular follow-up in apostrophe, which showed severe oligohydramnios and small for gestational age. So the obstetrician immediately admitted her, and she was planned for delivery. Fetal echo, by the way, showed severe TR with Epstein anomaly. That's the only thing that we could find on fetal echo at that time. Because of fetal distress, LSS delivery was done. The child was born at 32 weeks at 1 kilo weight, and echo confirmed diagnosis. The child was in distress, so she was ventilated and put on procedural infusion because saturation was not maintained. Echo at that time after delivery showed Epstein anomaly grade 4 with severe TR, pulmonary atresia, minimal functional RV, grade 4 RV dysfunction, RV atrialization with PTA dependent circulation and PA size of 2 millimeter, 1 to 2 millimeter size. So now the question is what to do with this baby with 1 kilo weight, whether to just leave the baby alone as it is and go for comfort care, or take the ventilator off and then accept defeat. The other option was to do a shunt to improve pulmonary circulation. Another option that we were thinking of is perforate the arteritic segment of pulmonary valve, as Dr. Nageswara told. But in the 1 kilo, I think it would have been a little difficult. Finally, we decided on a stance operation where we closed the tricuspid valve and a systemic pulmonary artery shunt was placed. The problem with perforating the segment also would be that the child would then have a free PR and a free TR, which would be very bad for the baby. So at 11 days of life, the child was taken for surgery, explaining all possible risks. We told about 50% risk that the child might not make it because it has not been attempted till now. I think this is one of the first in the world that got operated for open heart surgery at 1 kilo weight. We did a tricuspid valve closure and we did a systemic pulmonary artery shunt with 3 millimeter size. Now the problem with the 3 millimeter size BT shunt in a baby with a 1 to 2 millimeter size PA is the management of flooding of the lungs, because the amount of blood coming through the 3 millimeter artery is much more than what would be required for the baby. So we had a crowded time adjusting the PA pressures and adjusting the flow. This is the baby after surgery. As you see, it's just about the size of my hand. And this is him when he came back after 1.5 years. He underwent bidirectional Glenn shunt, and he's en route for single ventricle palliation. He was in the hospital for 27 days, and fortunately we could get him out of the hospital. Now, all this brings us back to how this is possible. Survival of babies in such cases is basically due to technology. The advances in the technology of obstetric management, of cardiology, of cardiac surgery, of postoperative care, all this is required to maintain a baby of 1 kilo size to go through a surgery and come out successfully. The advantages in technology that we are talking about, as I said, is on obstetric management, cardiology management, anesthesia, surgical care, and intensive care. Obstetric management is very essential because they need close monitoring. You need a NT scan which shows us any possible anomalies in the fetus. Precise fetal diagnosis is essential for diagnosing a problem in the baby. Again, a team-based approach would be the best for the child. And such children are better cared of in level 4 or 5 centers with a high dependency unit where the mother can deliver the baby, child can get operated, and then both mother and child can be discharged. Cardiology management, as I think Dr. Nageswara has mentioned, we would be able to manage most of these children with a variety of instrumentations and surgeries. But fetal echocardiography is a very exacting task which I'm sure needs skillful assessment. Now there are instances of fetal interventions like fetal arrhythmia management. Dr. Nageswara has done a fetal aortic valvotomy also, which has done well. Postnatal diagnosis and interventions are very essential in these children. And pharmacological interventions like PG infusion. I think PG infusion has saved a lot of babies after introduction because those children with duct-dependent circulation wouldn't survive without these. Nitric oxide is another very important way of saving lives. The hypoxic hypercarbic ventilation that was actually used in this baby which I talked about, 1 kilo child with 3 mm shunt. What we do basically, the principle is that oxygen is going to dilate the artery, carbon dioxide is going to constrict the artery. And if you want to balance the circulation in the systemic and the pulmonary circulation, you need to balance these two, oxygen and carbon dioxide. So we allowed the baby to be a little bit hypercarbic, say PCO of 50, 52, 55 at the most, so that the child's lung would not get flooded. And the other thing that we did was we extubated the baby onto room air instead of going on to oxygen inhalation. Another important method of management would be pulse oximetry screening for all newborns. I think this is being done in China and also in several Western countries, where every child born would be monitored by pulse oximetry. Anesthetic management, again, there have been significant advances in sedation, paralysis management, maintenance of anesthesia, post-operative pain relief, which we have been using dexmedetomidine, which is a very useful drug for maintaining babies of small size who are unable to express their pain or unable to express their discomfort. These children on dexmedetomidine do very well. They're breathing normally, they can interact normally, except that they're sedated and pain-free. Inotrope management and vasodilator therapy also has been significantly improved. Monitoring-wise, VIS, NIRS. Ventilation strategies also are very, very important in managing these children. Leothyroidine has been shown to improve the function after patient put on bypass. Weaning strategies to manage children with heart disease. When they're coming off the ventilator, it's a very, very delicate time, and they might need a non-invasive ventilation. Surgical management, I think, would be dependent on all these people, and in addition to perfusion technology also. I think perfusion technology is the one which has driven cardiac surgery as a whole. When a patient could be safely put in bypass and taken off bypass, that's the landmark point when cardiac surgery was possible. Hemostasis, blood conservation strategies, newer patches like decellularized patches, mechanical circulatory support devices like LVADs, BiVADs, ECMO. In children, we would prefer to have a Berlin heart because the priming volume is very little. The smallest one would be around 10-15 ml of priming volume would be needed, unlike in adults which need a larger volume. And the VADs cannot be implanted in babies. I have been fortunate enough to work with the Berlin heart when I was elsewhere, but in India I think it's a little costlier. It costs about 85 lakhs to a crore for management of patient. Perfusion management, as I said, was the landmark event that happened. We have been able to miniaturize the circuits, newer oxygen technology, hypothermia management. The other important advance was delineator solution and custodial solution, which we can stop the heart for longer periods of time rather than give frequent cardioplegia solutions. And we also use higher hematocrit rate so that the child's brain and other organ functions better. One other thing that we have been using is ultrafiltration. We use modified ultrafiltration, but also conventional zero balance dilution ultrafiltration also are available. Again, postoperative management by positive pressure ventilation or negative pressure ventilation also. I think I'm running short of time. I'll just run through this. Mechanical support devices. Weaning of ventilation is another very important time when children are having a difficulty in breathing against the ventilator. So there's a possibility of neurally adjusted ventilator assist using probe in the stomach, which will detect the diaphragmatic movement, and that will help the baby to breathe. Special cases, HLHs can be managed with valvotomy, by fetal aortic valvotomy, LV outflow rehabilitation can be done, MAPCAS, localization. TGA with PS, there has been recent interest in Nikaido procedure.
Dr. Girish, I am sorry to interrupt you. I think you have to.
Okay, I'm just running through this.
I think you have to.
The last two slides, I'm sorry. Again, the last one would be the heart transplant, which is the light at the end of the tunnel where patient's heart's failing. Of the most recent one is the transporting a dead heart using a circulatory device, which has been generating significant interest. This device actually preserves the heart while transportation. The heart is taken out of a dead patient. Basically, it's non-beating heart, which is taken and then connected to the circuit, and then the heart's given nutrients which makes the heart beat again. Of course, the duration of ischemia is very important, but this would help the heart to be transported to long distances across, say, even continents if needed. This is developed by UCLA, but has been marketed by Transmedics from Germany. The cost is about $240,000, which is about, I think, close to 40 crores, I think. Thank you very much.
Thank you, Dr. Girish, for your presentation. And I'm sure that it's very challenging to manage these sick children and very small children. And as you rightly pointed out, that it needs a multidisciplinary approach and for the stabilization and management of these children. I think if you have any questions from the audience, maybe one or two you can ask. Or if there are no questions, I think we will conclude this session. I think.
Well, that concludes the session now, and the next session will be Professor Krishnam Raju Oration, Device Therapy for Heart Failure. And the speaker would be Dr. Balbir Singh, and before that, but I would like to request the chairpersons to come on to the stage, Dr. B. Somraj Garu, Dr. Umesh Chandra, and also Dr. P.C. Raj Garu to come on to the stage. And to cue the introduction of today's session speaker, Dr. Balbir Singh, I request Dr. Ramesh to give a brief intro.
It is indeed an honor and privilege to be introducing Dr. Balbir Singh. Sir is a senior interventional cardiologist and chairman of electrophysiology and pacing in Medanta Medicity, Gurgaon, Haryana. He is a renowned cardiologist and cardiac electrophysiologist, graduated from Maulana Azad Medical College, completed his cardiac fellowship at GV Pant Hospital. He joined as faculty at the prestigious AIMS and published widely. Subsequently practiced at Batra Hospital, later joined Dr. Naresh Trehan and his team at the Escorts Heart Institute, later at Indraprastha Apollo Hospitals, New Delhi. Dr. Balbir Singh did pioneering work in RFA radiofrequency ablation and is well recognized for his skills in ablating atrial fibrillations as well. His work on primary angioplasties and cardiac care of the sick won him many accolades. Dr. Balbir Singh has been awarded many prestigious national and international awards. He was honored with Padma Shri by the President of India in 2007. So he is the founder secretary of Indian Heart Rhythm Society and has served as the Secretary of Cardiology Society of India. He has been invited as faculty for several international meetings. He has been on advisory panel of Asia Pacific Society of Electrocardiology and has organized several workshops with international faculty in the field of cardiology. Dr. Balbir Singh, it's our pleasure and honor to
Respected chairpersons, Professor Soma Raju, Dr. Chandra, I would first like to thank Dr. Kasturi for having invited me here for this oration. It's a great pleasure and a great honor to be here with you. And I'm going to discuss a topic which is very close to my heart, and I think we can do great wonders to the patients by putting in simple devices. And my interest would be on this ECG and trying to tell you how to identify patients and how to get the best out of cardiac resynchronization therapy. So in patients who have this kind of an ECG where you have a broad QRS, you have dyssynchrony. So a broad QRS itself tells you there is dyssynchrony. The dyssynchrony could be at the atria, could be between atria and ventricle, or it could be within the ventricle. So we have to identify based out of the ECG, not by the echo, but simple ECG to help us understand what it is. Now this diagram looks complicated, but it is not so complicated. We have left bundle branch block ECG here. I will elude the diagnosis of left bundle branch block because that's one of the keys to success to this therapy. We have 3D electroanatomical map here. The red area tells you the impulse is earliest here. So this is minus 63 and this is plus 86. So how do we know the impulse is earliest here is based on the electrogram that is recorded from this area. This is the right ventricle, by the way, and this is the left ventricle. So we compare this electrogram which appears in these areas to the QRS complex and then decide where the impulse was earliest. So if we take red as the earliest and this blue as the latest, we realize the right ventricle in left bundle branch block, this is the face telling you that this is an LAO projection. So this is the septum, this is the left ventricle, and this is the right ventricle. So somewhere in the anterior part of the right ventricle in left bundle branch block, the impulse is earliest. Then it travels like this and goes latest to the lateral wall of the left ventricle. On the contrary, if you take right bundle branch block, so we will just concentrate on left bundle and right bundle block. On the right bundle block, what you see is since this bundle is blocked, so the impulse is earliest here on the left ventricle side and is the latest on the right ventricle. So it looks little bit inversed from this part, except this stimulation of the left ventricle is different. So these two activation patterns are completely different, and it has a huge relevance to what I'm going to talk. So if I put the whole thing in a nutshell, in a left bundle branch block, what you have is a U-shaped pattern of activation of the left ventricle. You have the right ventricle which is activated first, then it goes down the septum and goes up into the left ventricle. So it is a U-shaped pattern of activation of the left ventricle in a left bundle branch block pattern. This is true for patients who have heart failure or who do not have heart failure. The relevance is that if you have this kind of an activation pattern, the left ventricle does not get enough time to produce a synchronous contraction from both the septum on the lateral wall. This results in what is called as interventricular dyssynchrony, and this could result in ejection fraction dropping over a period of time, or if the ejection fraction is less, it can become worse over a period of time. So with this idea, I remember when I was a DM resident in the Journal Club, I read an article on dual chamber pacing in heart failure, and it was seen in that group of patients that 4 patients were taken off the transplant after a dual chamber with pacing. However, dual chamber went out of vogue after that, but came in CRT, and that was a great outcome change for these patients. So what CRT does is another lead in the left ventricle so that you pace between the right ventricle and the left ventricle and remove this dyssynchrony. So what you want to achieve from that ECG is, this is from one of our patients, is that the left bundle branch disappears. Now you see a Q wave in lead 1, which you never see in left bundle branch block, and you see a Q wave in V5, V6, which again the left bundle branch pattern has completely disappeared. And look at the cures, it is so narrow. And look at V2 showing an R wave, telling you that left ventricular forces are now more prominent. So this ECG tells you there is now dyssynchrony converted into synchrony, QRS can becoming normal, and you develop Q waves which couldn't have been possible with left bundle branch block. This is just to show a case example of making things look an intervention way to do it. Most of us, we see that there are less number of electrophysiologists in this country, so interventions also have to get into this therapy so that we can offer it to many more patients. So this is an interventional way of doing it. This is all live recording, so there is no way it has been edited. So this is an Amplat's diagnostic catheter. There is a sheath from St. Jude, which is the sheath which will go to the coronary sinus. Now this Amplat's has hooked the coronary sinus. You can see how it can hook the coronary sinus, and you can easily see the tributaries. Once it hooks, you can get the catheter deep in to the coronary sinus and push in the sheath over it. So it's not a very difficult or challenging procedure, and generally takes half an hour to 45 minutes to complete the procedure. But the benefits are huge. The huge benefits are on multiple studies. So the first initial studies were to look at hemodynamics and to look at NYHA class. So clearly the NYHA class was improving, and so were the hemodynamics. The hemodynamics were studied by looking at the CPET studies, looking at VO2 max and mean arterial pressures. So this was all non-invasive studies, and they were looking very outstanding. So these were the initial studies which made the concept that acutely hemodynamically CRT is improving the patients. So from a mechanistic and observational studies, it went down to randomized controls trials, and from 2000 to present, there have been many randomized trials on this therapy. So you can look at the last decade and the number of randomized trials that happen, and imagine each of the trials kept increasing the number of patients because the optimism kept increasing. One important thing about all these trials is summed up in this last note, that all are positive trials. So I compare this to statins, where most of the trials come positive. So if the therapy is robust, all trials will be positive. You have no dichotomy. You don't have one trial telling you this, another trial telling you this. So all trials are positive. But we have to read between the trials and try to understand what's happening. So we agree CRT improves functional status, decreases heart failure events, improves overall survival in patients, carefully selected patients with ejection fraction which is reduced. So the carefully selected word is very important. So again, showing multiple trials with their positive results. So let's look at two trials which will make things even more clear. This was CARE-HF trial, which looked at class 3, class 4 patients, ejection fraction less than 35%, QRS duration more than 120 milliseconds, control group and a CRT group. Mean follow-up 29.4 months. There was improvement in primary endpoint, which is all-cause mortality for a cardiovascular or a hospitalization for cardiovascular. P-value is 0.001. Clear-cut difference. Most important was this, all-cause mortality being reduced by a trial in class 3, class 4 patients with reduced ejection fraction, so which is very robust. And this reduction in mortality, if you compare against beta blocker or ACE inhibitor trial, is even more better. So you can see that how robust is the therapy in reducing the mortality. And if you look at the mean ejection fraction improvement, it was about 7% in this CRT group. So we went on to less symptomatic patients. So we come to class 2 or class 1. So they may have been previously symptomatic, but you have class 1, which is nearly asymptomatic patient. QRS more than 120, so more ambitious. EF less than 40%. So even a more ambitious trial comparing optimal medical therapy with CRT. So they were patients who underwent a CRT implant, which was successful, they were randomized to CRT being off or CRT being on. So patients had a placebo effect of a device. That means the CRT was off, but they had a placebo effect. The follow-up was 12 months. And again, the primary endpoint of all-cause mortality and worsening heart failure or hospitalization was taken. And secondary endpoint was important, a change in L systolic volume index. So more ambitious trial, and it showed improvement in all the parameters, including the primary endpoint and the reduction in end systolic volume index. So we went from class 4 symptomatic to class 1 symptomatic QRS broadening. So that also showed that the remodeling of the ventricle is changed when you put the CRT on than you put it off. So very, very clear indication with p-values which are highly significant of improvement in the ejection fraction and improvement in end systolic volume. So we had multiple trials as summed up here, which initially were looking at NYHA improvement, then looking at heart failure hospitalization, then looking at mortality, then looking at less sicker patients, and all showing positive results. On this slide, we see compare RV pacing against BIV pacing in patients who do not have heart failure. So this was the Block HF trial, which said that if the ejection fraction is less than 50% and patient needs a dual chamber pacing for a complete heart block but does not have heart failure, the improvement in the maintaining of ejection fraction by IV pacing is better than by RV pacing. So we are now going to another era where we say that if a patient has ejection fraction less than 50% and will need pacing more than 90%, he probably will be benefited more by IV pacing than by RV pacing. So benefits are tremendous. However, one has to remember this, that the non-response rate can be as high as 25 to 50% using the echo indices. So if you are very sure that you want to look at echo parameters, you will have some failures. And if you look at only clinical parameters, you will have less failures. So there are several reasons for these failures and we have to address them. The patient characteristics, device-related features and programming and device lead positioning on follow-up. So the ECG is the key to patient selection. The QRS width and QRS morphology. There are two things. Echo has proved a failure. Echo CRT trials proved to be a failure in this group of patients. So which is important, QRS duration or QRS morphology? So multiple trials had criteria of 120, 130 or 150 milliseconds in these trials. And let's look at what happens to the response according to the QRS duration. So as the QRS duration increases, you get a better response with CRT. But when the QRS crosses 190, you start getting a worse response. Look at these confidence intervals, they get worse because they get really worse patients. So as the QRS increases, the best response you get is at 150 milliseconds. You see the best response is just when the QRS is between 150 to 160. So this is one of the indicators of a good prognosis if you can get a patient like this. Then we have morphology. You have LBBB, non-LBBB or RBB. If you compare LBBB, you have excellent response. RBBB is very controversial, the response may not be as good, and IVCD is worse. So we know that LBB is the best responder, and this group of non-LBB, how to select patients in this group of non-LBB. So it's important to know that the definition of LBB, you have to have R wave which is notched in lead 1, AVL, V5, V6, and absence of Q waves in V5, V6. Let's look at RBB and response to CRT. This is a publication which says that if we compare the hazard ratio of RBB, LBB, you clearly see that LBB does much better. So the physicians and patients should be aware of likely reduced benefit in patients who have RBB with a QRS which is broad. However, there's a caveat in this. Let's look at these three group of patients. This is a patient who has right bundle branch block. This is a 3D map which I showed you previously, where you see the RV has the last activation. This blue color is the last activation. Look at this ECG. This is a very important ECG. This patient also has RBBB. But if you look at the limb leads, lead 1 does not have an S wave. It has a notched R wave. Lead AVL does not have an S wave. Now you look at this ECG, there is an S wave here and there is an S wave here. Now this is a clear-cut RBBB. This is a LBB masquerading as RBBB. So if you look at a 3D map of this particular patient, you see there is delayed activation here and there is a delayed activation on the left side. This patient could benefit with CRT. So just looking at limb bleeds helps you to decide in right bundle branch block which patient is likely to benefit. And this is the left bundle branch block which I already showed you. So both QRS duration and morphology are important, but there are some studies which say that even morphology is even more important than the QRS duration. Let's look at this group of patients from literature. This is an RBBP. He underwent CRT. His EF improved from 17% to 40%. Let's look at his ECG. There's RBBP. Look at lead 1. There is no S wave. It's a notched R wave. Look at this patient. He has a big S wave in one AVL. This patient died 2 months after CRT and this was a responder. So within RBBP, you have to look at patients who are masquerading LBBP in RBBP. So this is a very important concept which we must learn and remember. Second is lead placement. Placing the lead in the right position is very important, and we have realized that basal position on the lateral and mainly posterolateral, dead lateral, and sometimes when you don't achieve it in the anterolateral position is helpful. So this is very important. Then there are new methods, adaptive CRT and sync AV CRT. So I just completed the sync AV CRT first in man clinical study with 20 patients, and it's so absorbing. It's an enormous thing. It's going to reduce our failure rates clearly. Then there is a multi-point pacing which will also come to. Let's look at in sync AV pacing. So this is a patient who has left bundle branch block. So this AV interval, if you look at this PR interval, it is short. So if you do not give importance to the AV interval, what will happen is that you do the CRT pacing. The AV interval is short because this patient doesn't have an AV nodal block. So his AV interval is short. Now you will have a pseudo fusion with the pacing. You get a pacing spike, but the impulse is fused because the intrinsic conduction across the AV node is fast. You get a pseudo fusion. So how to avoid this was a programming parameter which was always available with us, but we never used it. And this idea came to me and I suggested to the company, and then we had the global team coming in and we did the first in-man study. Let's look at this patient. Now this patient is undergoing a IV pacing in the lab. This is the QRS and the first 5 beats left bundle branch block. We switch on the sync AV. Look at the pressures in the femoral artery. You see a complete change with 1 beat. The cardiac output improves, so the pulse pressure improves, the diastolic pressure goes up, the systolic pressure goes up. 1 beat is all that is required to show a good hemodynamic change. 1 pacing beat and you see a good hemodynamic change. Let's look at this ECG. This is the ECG. You see the sync AV is -70. It means that this pacing will happen. The device will calculate the AV delay. It will pace -70 of whatever the AV delay would be. This patient's AV delay was 130. We got this ECG which looks like normal, and nobody would believe me that this is not somebody else's ECG until I show you that this first beat is LBBB and I put the device on here. I put the sync AV -70 here. This first beat is LBB and then this is the paced beat. Can you imagine this is a normal complex, and this is produced because I have produced this -70. And if I do the nominal settings, which was 120 and 100, we are not getting this kind of an ECG. And this patient was a super responder. EF went to 52% at 4 months. Out of these 20 patients, we were able to achieve in 8 patients QRS less than 100 milliseconds by just manipulating the sync AV study. So having completed this 20 patient study, I have now got the global lead to do this trial, a randomized trial on this. Now this is to show the same thing, that we put it off now. The first 2 beats are paced and then we put it off. You have LBB after that, and the first 2 beats look as if this guy never had any problem at all with his QRS. Look at this beautiful Q wave and look at this QRS complex and then look at this Q wave. Just by manipulating the AV delay. So what about CRT in narrow QRS patients? It's a hopeless situation and one should not even attempt. I'm wary of patients even in 130 milliseconds, so 120, 130 we avoid it. 130 and beyond is what we are using as our cutoff. What about patients who have scars? You know, we are not very careful in looking at scars, but it is clear that if you pace within the scar, you have less good response. As a result, there is another algorithm which is called multi-point pacing, which means that if there is a scar, you bypass the scar by pacing at 2 sites in the left ventricle, which can be possible by using these quadrupolar leads. So you have 4 poles and you have 4 multiple vectors that can be developed. So you can pace at the this point, between this point and this point, and you can pace between this point and this point. So you'll have 2 vectors. This is called multi-point pacing, and this also has also shown to be of some more benefit in patients who have scar. So if I go down to my last 2 slides, this is from the NICE guidelines. How do you select patients? So they still continue with 120 milliseconds. So they divide this 120 milliseconds to more than 150 and between 120 and 150 milliseconds. Then they say non-LBBB and LBBB. So in non-LBBB, they write predicted poor response to CRT, especially a right bundle branch block. And in LBB, again, good response, even if the QRS duration is 120 to 1, and more than 150 is even more positive outcomes with LBBB. And with non-LBBB, if you have right bundle with left anterior hemiblock or left posterior ventricle, there is reduced benefit compared to LBB, but still there is benefit. So in conclusion, I would show this long-term slide, which shows that if you look at the long-term real-world data with the use of these devices, this is ICD and this is CRT, you clearly can change the outcome, particularly in patients if they are less symptomatic. So intervening early with CRT is very important. If you look at this class 2 patient, the line is flat. Over 5 years, this patient does not have a poor outcome of using an LVAD, heart transplant, or a death. This curve is flat over next 5 years. So intervening early with these devices can actually change the outcome and the natural history of heart failure in patients who have left bundle branch block and reduced ejection fraction. Thank you very much for this honor to be here.
Thank you, Dr. Balbir. It was a wonderful talk. I'm sure you particularly brought out the issues related to what looks like RBBB and masquerading bundle branch blocks. Because now cardiologists in training or cardiologists coming up don't look at ECGs at all these days. Thank you very much.
Thank you, sir.
I must congratulate the speaker for the wonderful. I must congratulate the speaker for the excellent presentation, and the CRT is helping leading the quality life in the heart failure patients. Thank you very much.
Thank you, sir.
I invite Professor Sai Satish sir to give a memento to Dr. Balbir Singh.
Box is there.
We are moving to the next session, and for this session I will request the chairpersons to be Dr. Krishna Kishore Reddy, Dr. R.K. Jain, Dr. Sridhar Kasturi, and also Dr. Kaul M. Sitaram. And I request also the moderators to come to the stage. Dr. T. Sadanand Reddy, Dr. Venkatesh Kumar, Dr. Y.P. Raju, Dr. Srinivas Reddy, Dr. Chaitanya, and also Dr. Ganesh Mathan. In this session, we're going to discuss about acute stroke and interventional approach. And the speaker would be right now Dr. Suresh.
Hello, Dr. Ramesh is going to be chair the session also. Thank you.
Good afternoon. I thank CSI and Dr. Sridhar, Dr. Ramesh for giving me this opportunity to talk on stroke. I'm a radiologist trained in neurointervention and vascular interventions. So I will be talking briefly about the devices and few of the cases that I have done in the last 4 or 5 years. So from a cardiologist point of view, what is the difference between cerebral ischemia and cardiac ischemia? The window period as well as the modes of treatment, both IV as well as vascular intervention, the endovascular interventions are almost similar, whereas the triage difference will be there in the form of imaging plays a more important role in case of cerebral ischemia, and the reperfusion changes like hemorrhage, intracranial hemorrhage will cause catastrophic hemorrhage, that can lead to death. And primary stenting is well approved in cardiac interventions, whereas it is not approved in cerebral ischemia and cerebral stroke, whereas thrombectomy is approved. It has got a class 1 evidence for thrombectomy, but intracranial stenting as of now, it is not approved for acute strokes. So what do? We select cases depending on few criteria, unlike ECG or other cardiac markers, we have imaging here. And we select cases of only proximal vessel occlusion, the large vessel occlusions, and in cases where the core, infarct core is small and the penumbra is more and good collaterals are present. In those cases, we select those cases. And what are the large vessels? Basically, large vessels are which are around the circular fillis. In this image, you can see the A1s, M1s, and ICA, as well as basilar artery and vertebrals. These are the large vessels we target, and we reach the target site with the help of microcatheters and aspiration catheters. So there is, as I was discussing, there is a class 1 evidence for thrombectomy in cases which are coming up to 6 hours, especially in anticirculation stroke only. There are no guidelines as of now for post-circulation strokes. And it is recommended to do interventions with the help of stent reverse. This guidelines was made in 2015 by HASA. But as of now, the additional set of the thrombectomy device, that is the aspiration catheter, also has come. So we select cases based on energy score and aspect score. These are all basically the imaging criteria, and which fit the case into small infarct core and good penumbra. So we do cases up to 8 hours, especially in anterior circulation. In posterior circulation, we'll go up to 24 hours. And once we decide the case to be selected, we'll go by thrombectomy. And the thrombolysis, intra-arterial thrombolysis, IV thrombolysis is indicated in less than 4.5 hours, but intra-arterial thrombolysis is not being done as of now, and there is no evidence for that as of now also. Except for in case reports are in off-label use is there, but intra-arterial thrombectomy is the modality of choice if you want to do these stroke interventions. So what are the devices that have changed the perspective of intracranial interventions, especially in acute stroke? There are 2 devices which have changed the complete outcome of intracranial interventions. The first set of devices are called stent reverse. Basically, these are microcatheter deployable self-expandable stents, which can be deployed into a 2 mm vessels or 3 mm vessels also distally into the cerebral circulation. So once they deploy across the thrombus, they'll engage the clot into the struts of the stent, and that can be removed en bloc with the microcatheter after a couple of minutes. So these are called stent reverse. We have around 4 or 5 different kinds of stent reverse in the market. The most commonly used one is solitaire. So the second one is it's a kind of guiding catheter only, but it's a very flexible guiding catheter with a large bore distally. So it has got around 5.4 French of distal OD, and the ID will be around 0.60 or 0.64. So we have a few aspiration catheters which can be either connected to a pump proximally or can be aspirated with a 20cc syringe also. So both these devices have got good revascularization outcomes in the range of 80%, achieving TICI-2B and TICI-2C results. So the catheter will be stuck to the thrombus proximally, and it will be aspirated once with the clot in situ. So clinically we have 3 settings in which we will get strokes. One is the in-cath lab stroke, which is very maybe monthly once or twice in a busy cardiac cath lab will get, which can be the large vessel strokes. And the second one will be like in a hospital stroke. Patient will be having, patient underwent surgery, or patient who is having other problems like atrial fibrillation, throwing cardioembolic strokes distally into the cerebral circulation. And the third type, which is more common in our setting, is the strokes in the ER setup, the emergency. So the way we deal, the guidelines are mainly meant for strokes in ER, but how we deal with the strokes in cath lab is a little bit different as compared to the rest of the 2 clinical settings. So I will be showing few of the cases. So this was case of relatively young lady, 32-year-old female, underwent subclavian artery thrombus extraction, sudden onset aphasia as well as right hemiparesis. So incidentally I was doing a case in other lab, and I was called for it for probable opinion, and we suspected probable left IC involvement, and you can see that there is left M1 is okay, but distal to that there is paucity and there is retrograde filling of the branches, you can see. The same in the lateral projections, you can see the paucity of the entire branches here. So the left M1, distal M1 and M2 branches, they are getting retrogradely filled. So I was stuck up in another case in the lab. We thought instead of wasting time, we'll give IA therapy, IA thrombolysis. Although it is offline, we thought we'll do it instead of wasting time. So over 10 minutes, 8 mg of altiplase was given for her. So to our surprise, it completely opened up with thrombolysis itself. No intervention, no thrombectomy required for this particular case. So the MCA circulation completely got open. So on table she completely, like, dramatic improvement was there. She was telling her name and she was moving her right upper limb as well as leg. So this was one of those cases of intra-arterial thrombolysis which was done on table without wasting much of time, and the patient recovered significantly. This was a case of stroke in ER referred from an outside hospital with relative contraindication for IV thrombolysis. So the imaging was done already outside, and it showed left MCA ischemia, and in the right side image you can see the left M1 got occluded. And we took the patient for cath lab. You can see good collaterals coming from the ACA. So this is a good sign that the patient may improve after intervention. So we put the microcatheter across the thrombus site, and after stent removal, you can see good recognition of the MCA and its branches. So she was discharged on day 7 after, and she was walking after that. So posterior circulation, this is not straightforward always. We do thrombectomies. I think I'll show you a couple of cases, then I'll close it off that. So this is also a case of basilar occlusion, but in this case also we employed the stent remover. So it got opened with the microcatheter in situ and after stent placement. So you can see this is the microcatheter, so across the lesion. But it got open, but there is an underlying atherosclerotic plaque is there. So it got occluded on table in front of us only. So we tried to do the stent remover technique again. We did 3 times. Every time it is opening for maybe a couple of minutes and it's again closing. So then we thought it's an unstable plaque. We should do a plasty for it. So we did a plasty with the cardiac balloon of 2 mm diameter with a very graded pressure inflation. So this was the check angio showing little bit distal emboli in the left PCA, but otherwise the vessel got open nicely and it stayed patent in the next 1 week. This is a follow-up MR showing that the basilar is not seen here in the before picture. You can see basilar is seen. Tandem lesions also we treat. This is a case of free floating thrombus in the carotid proximally, and distally there is distal M1 occlusion. And in this difficult choice to take whether to treat both of them or only distal one which is symptomatic. And in this case we treated only the distal one because the proximal one is prone to it's not right. So this was the MEC catheter and the guiding catheter, the aspiration catheter is placed distally, and this was the thrombus that was sucked out as a heart block, and this was the post-check angio showing good revascularization. We left the proximal free-floating thrombus with medical management, and patient improved dramatically. So I'll skip this lesion. This is a case of vertebral artery dissection with the distal basilar occlusion. So we went across the dissected segment of vertebral artery and did thrombectomy. So this was the catheter that is growing across the vertebral into the basilar artery. And this was the stent reaver. This is how the thrombus embedded within the stent reaver. Two passes in two fresh plaques, fresh thrombi have come. So we can see the opacification of the basilar artery as compared to before in the latter picture. So to conclude, we do only large vessel occlusion treatments. The distal, like M2 and M3 are distal P2, P3 we won't treat. And the case selection is very important, which is based on imaging. And we do thrombectomy rather than thrombolysis. Thank you.
Dr. P.C. Gupta, please.
No discussion, sir, because of the lack of time. 1 hour late. Train is running late, please. Yesterday only it was 1.5 hours, 2 hours. Okay, thank you. Please excuse. Thank you.
Good afternoon, ladies and gentlemen. I thank the CSI for this opportunity to talk about aortic aneurysms. I will briefly talk about abdominal aortic aneurysms, when to intervene, how to intervene, a little bit about ruptured aortic aneurysms, and a little bit about thoracoabdominal aortic aneurysms. I think thoracic aortic aneurysms, arch aneurysms, we are more or less clear on the approach that we have for the disease. Now, when we talk about abdominal aortic aneurysms, we are talking about EVAR versus open. Now, EVAR has good early results. However, more re-interventions in the long run. A more dedicated surveillance is required. Higher radiation during procedures, and especially when we look at complex EVARs for juxtarenal, where we put in snorkels and chimneys and stuff, there is a definitely increased risk of cancer for patients. And there is a study which came out recently which also showed DNA changes not only in the patient but also in the operator when you deal with complex aneurysms and spend long time in the cath lab. There is a small risk of delayed rupture, and of course it is useful in selected high risk patients. When we talk about open, there is a higher early mortality, but it's a durable repair. There are increased interventions in the first 4 years and good for complex abdominal aortic aneurysms. Natural history, we generally look at the increasing risk of rupture from 5.5, and this is the level that we generally look at intervention for these patients. So decision making, when we see patients who are smokers, patients who are hypertensive, especially uncontrolled hypertension, patients who have a family history, these are patients who are going to be at a higher risk of rupture. And there we should have a lower threshold for intervening. There were a couple of studies on the small aneurysms, the UK small aneurysm trial and the ADAM trial, which did not show any benefit of early intervention. However, this patient published last year in the NAJM looked at different practices in UK and USA and found that small aneurysms were tackled in the USA, leading to a reduced risk of death due to aneurysms. So in UK, where the aneurysms were treated at a much larger size, that is around 6.3, there was a much higher rate of patients presenting with ruptured aneurysms. So we might be looking at a time when we start considering intervening for aneurysms at a lower size, and our threshold for operating on these patients might change as devices become better or surgical risk comes down. Now, the basic decision-making algorithm, we look at the rupture risk, we look at the life expectancy, and we look at the operative risk. If the risks are too high, we go in for medical management. And two things which have shown some benefit in medical management, one is use of doxycycline, which takes care of infection and which also affects the functioning of metallic metalloproteases. And the second one which has some bearing is statins, which also seem to reduce the rate of expansion of aneurysms, besides of course improving the cardiovascular risk. So if we are looking at good anatomy, we go in for AVAR. Not so good, we go in for open. Now, early mortality in population-based studies, we see that the risk of open surgery has come down significantly. So recent studies, we are looking at risk of mortality of about 3% with open surgery, not very far from EVAR. And even when we look at results from the comparative trials where EVAR was compared with open surgery, we see that the risk of rupture is not the risk of mortality is not very high. So long-term outcomes, just to summarize, survival is very similar when we look at EVAR or open repair, but at about 4 years, the intervention rate comes down seems to go up in patients who have endovascular repair. A recent randomized controlled trial of endovascular versus open also showed that open surgery is as safe as EVAR and remains a more durable option. So looking at the other group of patients who are high risk and unfit for surgery, the EVAR2 trial did not find any benefit of intervention over surveillance. However, subsequent work has shown that EVAR might be beneficial in select patients. So what are the patients who might benefit? So patients who do not suffer from these, that is an increased age of more than 70, patients who do not have CKD, patients who are not in CCF, patients who are not using oxygen at home are relatively fit, and patients who do not have cancer. So these patients would benefit, but patients who have any of these risk factors may not benefit from EVAR. This is one of the patients that we have operated. So EVAR I would suggest for older patients who have a good anatomy, that is a long neck, a small size neck or a small diameter neck, absence of calcium, atheroma or clot in the neck, absence of significant angulation and normal or not too dilated arteries, because very dilated iliacs also, when we flare up the lower end of the stents, can lead on to endoleak at a later stage. There are newer devices like the Eurofix and the Nelix. We personally have no experience with these, and I don't think these are available for our use as of now. Open repair, we would look at younger patients, relatively fit patients, and in patients who have complex anatomy, I think open surgery is the way to go for AAA. Moving on to ruptured aortic aneurysms, 80% of them die before reaching the hospital. Open repair carries a mortality of 40 to 70%. EVAR trials have shown varying results, but lower early mortality has been shown in most studies, 20 versus 35%, that is EVAR versus open. There are no long-term benefits. So this is the age-adjusted mortality. We see that with intervention, it does come down. This is an algorithm developed by the Albany group, where they are looking at EVAR for ruptured aortic aneurysms. However, in our setup, it is really going to be difficult because we need inventory, we need expertise, we need a hybrid OR, because some of these patients we would need to open up, and this may delay definitive repair. This is one patient of ruptured thoracic aneurysm that we had operated. Another patient with ruptured abdominal aortic aneurysm where we went in for EVAR because this was a contained rupture and we had time and we could plan for EVAR. Moving on to thoracoabdominal aortic aneurysms, there is long-term data available only for surgery and not for interventions. Few centers have the expertise for open surgery as well as interventions for this complex group of patients. There is increasing interest in fenestrated EVAR and branched EVAR, chimneys, etc. Now, when I started practice, this was the opinion that this was the outlook that most of our physicians and cardiologists had towards aortic surgery, as if most of our patients would actually bleed to death, especially for thoracoabdominals. This has changed over time. Of course, there's a lot of metabolic changes which happen when we are treating these patients, including acidosis, hyperkalemia, and renal ischemia. This is what we normally do. We put the patient on a partial cardiopulmonary bypass. We use a fem-fem bypass so that we are able to perfuse the viscerals during surgery. So, surgical results, again, mortality, paraplegia rates are close to 5% with open thoracoabdominal aneurysm repair, and we are matching those results. So open endo techniques for thoracoabdominal aneurysms are complementary, and they should not be offered at random, but we should be selective. This is one of our patients with a type 3 thoracoabdominal aneurysm, which we have operated. You can see the catheters here which perfuse the SMA and the renal artery, and this is a follow-up CT scan. Another procedure which has been used by some operators is the hybrid. We have also done it, but we've not been very happy doing it because long-term results may not be very good. So this is a type 4 thoracoabdominal aortic aneurysm. You have the stenosed right renal artery, occluded SMA, occluded right renal artery. So we have done a debranching for this patient, followed by deployment of a stent graft, and these are the post-operative reconstruction images. So technically, it is possible to do any of these procedures. This is another patient with a thoracoabdominal aortic aneurysm, again, open surgery. To summarize, we should look at early elective intervention. We should not delay till it is too late. So we should be looking at intervening in patients before they reach a stage where the risk of rupture goes really very high. Select EVAR or open based on the patient and aneurysm factors and not what just you can do. Thoracoabdominal aortic aneurysm has good results in trained hands, whether we use open surgery or endovascular intervention. But I would say endovascular, the risk of reintervention is extremely high, and open surgery, if it can be done, would be a very, very durable option. So treat endo and open as complementary rather than as competitors. Thank you very much for your attention.
Thank you, Doctor. Kindly sit. We will take the questions in the end. Dr. Uday Kumar, please.
Good afternoon. This session will be dealing with the SFA. Just open that session. See, you are treating the femoro-popliteal disease in the established and emerging technologies. Here, the femoro-popliteal disease is always a Achilles tendon in the intervention management, because most of as we have reduced the restenosis and stent fracture in coronary disease, in femoro-popliteal disease we are not able to establish this, because most of them are underdiagnosed, asymptomatic, and most of these femoro-popliteal disease are associated with MI, stroke, and also have systemic atherosclerosis. Most of them are risk factors like smoking and diabetes, and they are more than 75 years. See, the treatment options are risk factor management, diabetic management, smoking cessation, BP control, and correction of hyperlipidemia, and antiplatelet therapy and walking program. If they are not subside with this therapy, then second therapy is pharmacotherapy, and third is the endovascular and surgical intervention. So the most peculiar thing in this SFA disease is the most longest vessel in the body, and because of it runs through the difficult muscle groups, this is responsible for torsion, compression, and flexion, and extension by the largest muscle too. See, this will have the fracture in the stent, so restenosis is very, very common. And there are two flexion points and few collateral sources, and occlusions are predominant. And this is the unique biomechanical properties of this vascular segment. You can see the early part portion where they have an extension. In the second portion here, it is produced to torsion. And third is the compression when it goes to Hunter canal. And the fourth one is the flexion. So these unique biomechanical properties, when the patient starts walking, the stents get through these biomechanical properties, and it leads to stent fractures and early restenosis. The options are plain balloon angioplasty. The positive predictors are short lesions, localized vascular disease, and stenosis and occlusions. There are good results. Patients which are non-diabetics have a good results, and the restenosis, residual restenosis is absent, then they will have better results. Distal run should be more than 1 vessels. If you see the task 2 guidelines, these femoro-popliteal lesions are categorized into 4 categories depending on the morphology. So the task A to C lesion should be treated by the end. This is the simpler diagram of task lesions. See, the balloon angioplasty is necessary for type A and type B lesions, where the lesions length is less than 5 centimeters, total occlusion less than 10 centimeters, and base stents are used for type A to C lesions, and DE stents you can opt to use for type D lesions. So initial results of balloon angioplasty results are about 70-80%, but after over a period of 5 years, the declines to 50%. So it's a bailout procedure. Stenting is indicated when it has a bailout procedure in most of the cases, like flow limiting dissections, residual pressure gradient more than 15 millimeter, and remaining stenosis more than 30%, and elastic recoil is seen after the angioplasty. So the poor surgical out candidate, like some patients we have severe distal tubular occlusive disease, inadequate distal targets, absent venous conduit, significant medical conditions where they are high risk for complication surgery, this procedure can be used. In these results also, the unfavorable things we can see in the occlusions, long eccentric lesions, diffuse atherosclerosis, and limb-threatening ischemia, and poor initial post-edit appearance like diabetes mellitus and congestive failure. So high rate of restenosis in the peripheral disease have necessitated development of new tools to improve the vessel patency, like DCBs and DEs are potentially minimize the development of neointimal hyperplasia. Cow stents also one of the mechanisms. So initial stents from the nitinol sulfexin stents, their first generation stents had longitudinally oriented bridges. Later on they had the helically oriented bridges there. So these are the improved designs, and if you see the results compared between the provisional stent with the direct stenting here, the provisional stent had higher restenosis rate. So the initially the regulatory stents are used here with the sirolimus stents, but initially had a superior patent rate, but the results were not maintained over 2 years follow-up in stage study. Later on, the Gilver PTX stent study was used. It showed better primary patent rates, event-free survival rate compared to control groups, and maintained at 2 years follow-up. So first regulating self-expanding stent was the Cook's Medical Gilver stent. It was approved in use in 2012, and after 5-year data showed with a better result and primary patent rate of 66% in the SFA and 43% compared to the plain PTC. The PTAV covered nitinol stent like Viban stents showed the better primary rates in the task lesions. This is the core Viban endoprosthesis. It has a nitinol support and ultra thin wall PTAP tube, and it's a heparin biopsy surface. And this showed it can be used in case of TAS D lesions. See, DCPS, the drug-eluting balloons, there is another solutions. They have no permanent scaffold, at the same time inhibits development of neoventricular hyperplasia. The 6 months results of Thunder, PMPAC, Levant and Festival studies show that drug-eluting balloons compared to controls are associated with significantly lower restenosis rate. Long-term data is still weighted. This is the, in fact, SFA study, this is the balloon which is drug-eluting balloon used by Medtronic. The 2-year study showed superior result compared to traditional PTA. It results of 87% patency rate. The Levant is a 2 trial in the June 2015 it was released. It showed the Lutinox stent is manufactured by the BARD or the standard PTA. The Lutinox DCB is, the results are better than the success. The other one, the recently cleared was Spectronics Stellar drug-eluting balloon. The results are weighted. The other devices which are used now is 2 new atherectomy devices by the cardiovascular systems. Forefront device, it is 1.2 centimeter diamond bract peripheral orbital stent system, and CSI's Viper-Y flex tip system. And definitely study is using the TurboVac atherectomy devices for 12 months. It showed 12 months results of 95% limb salvage in patient with CLI. So the recent one is the Shockwave medical lithotripsy balloon catheters. You can see here, which can be used for kidney stones. Now we developed for peripheral and coronary vessels, and it also can be used in aortic applications. The Disrupt PAD trial, the lithotripsy system in calcified SFA and the Femoro-popliteal stenosis demonstrates safe and effective dilatation of calcified stenosis with no acute failures. So, see, this is the most problem with the femoro-popliteal system is one of the restenosis and calcification. Thank you.
Thank you, doctor. Any questions? Are we permitted?
A couple of minutes would be no problem, sir.
Right. I thank all the speakers for keeping to time, and we have saved some time for you. 1 minute. Thank you.
Thank you so much. And our next session is Professor K.V. Naidu Memorial Oration, Surgical Options for Congenital Heart Diseases. And I request the chairpersons to be Dr. A.G.K. Gokhale, Dr. B.V. Ramarao, Dr. K. Nageshwar Rao, and also Dr. Prasad Reddy Garu. And our speaker for this session is Dr. K. Shambamurthy. But I would request Dr. Sridhar Kasturi Garu to give the intro for our speaker.
Sir, you can. I am very much privileged to introduce one of the finest cardiac surgeon, Dr. K.S. Murthy. He got cardiac surgery from All India Institute of Medical Sciences and underwent advanced training in pediatric cardiac surgery in Green Lane Hospital, Auckland, New Zealand, and worked as a consultant, head of the Department of Pediatric Cardiac Surgery from under the Dr. K.M. Cherian in Chennai for 13 years. He has performed highest number of pediatric cardiac surgeries, that is over 13,000 in both states of Telangana and AP. And it is one of the highest numbers in the world from a single institute. His main interests are surgeries on newborns, single stage unifocalization, and performed the highest number of unifocalization operations in the country, which is the second largest number in the world. He has more than 100 international scientific publications. He is a peer review member for European Journal of Cardiac Surgery and Annals of Thoracic Surgery. As a social commitment, he conducts many free camps and medical CMEs for general practice to bring awareness on congenital heart disease. He has performed the highest number of heart surgeries for poor children under Arogyasri scheme. His aim is to provide the best medical care to children of all sections of society. He has trained many cardiac surgeons in India and abroad. He has over 8 innovative techniques in pediatric cardiac surgery. They go by his name, Dr. Murthy's techniques. He has performed many live surgical demonstrations in India and abroad. He is a skillful surgeon and innovative ideas. With innovative ideas and excellent academic background, he is the chairman and head of the Department of Pediatric Cardiac Surgery at Innova Children's Heart Hospital, which is situated in Tarnaka. Really, I am very, very glad to introduce you, sir. I request. Sir, don't curse me. Please, you come to honor, do the honor.
Dr. Somraj Garu, please come on to the dais, sir. Thank you.
Respected chairpersons, Dr. B. Ramarao garu, Dr. Prasad Reddy garu, and dear friends, Somraj garu. And at the outset, I would like to thank Dr. Sridhar Kasturi and Dr. Sridhar, Dr. Subba Reddy garu and Saidu, and giving me the opportunity to talk on the Dr. K.V. Naidu Memorial Oration. It is my present privilege to deliver a lecture on this great personality. And I have not met him, but I have seen him from a distance, Professor K.V. Naidu garu, during these IACTS conferences. And it's an amazing personality. But when I was asked to give a memorial oration, so I spoke to Dr. D. Prasad Rao garu and Dr. R.V. Kumar, because they were associated with him. Then they told me there's so much of about Professor K.V. Naidu garu. He's a student of Kurnool Medical College. He's the first MCH student from CMC Vellore, and he's the first qualified cardiac surgeon from AP. And he was professor in Hyderabad departments in Nizam Institute of Medical College, and also the Usmania Medical College and Sri Venkateswara Institute. And he started MCH cardiac surgery programs in NIMS, Osmania, as well as SFIMS. And he was the president of IACTS in 1995, and he was one of the founder member of the, our organization. And he was a very good teacher and academician. And I asked him what is his rare qualities. And as being a cardiac surgeon, he was friendly with both cardiologists and cardiac surgeons. And it's a rare quality to please cardiologists. And also, and he's an excellent human being. And I asked him what is his extracurricular activities, and he said, no, he always used to help the people. That's all. Any consultant birthday used to send bouquets and greet him and give like an unofficial holiday for him to enjoy with his family. That sort of a person we are talking on today. And he's ahead of the time, and he's a what R.V. Kumar said was that he's a Mahanubhavudu Telugulo. Okay, so it's very few people come across, and lucky to have him here in Andhra Pradesh. My topic was the surgical options in congenital heart diseases, and I know that you're all learned audience, and I need not much tell about these surgical options, but whatever I say, it reiterates what is the indications and all. And also today, and in the earlier session we had Nagesh Rao and Girish talking about such a excellent, complex interventions and surgical procedures in small babies and all. And we have progressed a lot. But but still, pediatric cardiac services has its own problems, and which is peculiar to the specialty and peculiar to the our country. And what they were talking about, even though we have developed, we sent rockets to the moon and all, but we have forgotten the Swachh Bharat. What I want to tell you, beyond indications, that social, economic aspects, as well as the philosophy involved with the specialty. The rule of thumb is the presence of congenital heart disease itself is indication for surgery or intervention. Very few diseases require intervention or surgery. The neonatal corrections in nutshell, the transposition of great arteries, duct-dependent pulmonary circulation, duct-dependent systemic circulation, and obstructed TAPVC. Why we have to do early surgeries? That the nature history is such, if you don't operate in early, otherwise next day you may not be alive. That was the reason to operate them early. The infant corrections are indicated conditions like ventricular septal defect, TAPVC, AV canal defect, truncus arteriosus, and AP window. In this, I would like to mention why we have to operate them early. Before they develop pulmonary arterial hypertension, if you close the defects, then they live like a normal children. It is more of a cure and without any medication. Otherwise, once they set in pulmonary arterial hypertension, even though you have done successfully closed the VST closure, but still residual pulmonary arterial hypertension, they have premature deaths, and also it's more of like a palliation. So always achieve for the cure rather than palliation. And preschool corrections are indicated like less severe form of heart diseases like atrial septal defect, small size VSTs, and DORV, tetralogy, single ventricle pulmonary stenosis, restly procedures. Why I am telling this, and these are the less aggressive, less risky procedures, and they can wait till preschool age. And see that even small VSTs, if it is outlet VST with AR, even though it's small, we should be closed. Otherwise, they develop severe aortic regurgitation. And almost all children should be operated before they go to school, young age, and small weight will not be a risk factors for this. And some of the asymptomatic children come to you, but you say that it may not require surgery, but it may not be true. It is abnormal S2, loud or long systolic murmur, any diastolic murmur, abnormal pulses or blood pressure difference in the limbs, and abnormal findings in chest X-ray and ECG, murmurs increase with exercise. They are the indication for closer look and see whether any other significant defects are there. The myths about the spontaneous closure of VST, because we always hear, we saw one doctor, he said it will close the VST, you wait, and by the time they come to you, they become asymmetric. But I know that you people know, but what I wanted to reiterate that how these VSTs, what sort of VSTs have a spontaneous closure and what sort of VSTs require surgical intervention. And if you look at the statistics, if you see a child at the age of 1 month, their chances of closure is like 80%. The same child with VST, if you see after 12 months, and the chances reduced to 12%, 25%. So older than 1 year, any VST get closed spontaneously. And also these large VSTs like perimembranous VST and supracrystal VST, they rarely get closed. So these are the differences where you have to see that, and once the patient develops pulmonary arterial hypertension, definitely that child requires early surgical intervention rather than to wait. So the conventional concept is pediatric cardiac services cannot maintain on their own, is financially not viable, and is a piggyback on adult cardiac program. And also this is the big mother elephant is the adult cardiac program, and the small baby elephant is a pediatric cardiac program. So the mother elephant has to be feed this small baby elephant, otherwise it cannot be survived. And if it is something dependent on some other specialty, it cannot make its progress. What it cannot help the children, and it cannot have a full potential of the growth. Then what is the peculiar problems in the pediatric cardiac surgery? It is a skilled job, technically demanding, long hours, hard work. All the bad things come for the pediatric cardiac services. And the physiology is entirely different from adult heart diseases. It is mainly congenital heart disease. It has tissue immaturity, and post-operative management is very essential. Otherwise, the safety margin is so less, and you see that mortality. And if you have a dedicated cardiac team, then you can perform more number of cases, improve the skills, and get an excellent results. That was the thing I had dreamed that, can we have the dedicated children's heart hospital where we can address all these problems. That is what that is how we have started in 2007, and in our children's heart hospital, that we thought, the collective efforts by doctors and parents and NGOs and government can do that, provide best care to all sections of the society. And you cannot ignore this RGC program in Andhra Pradesh and Telangana. And we started 2007. Fortunately, unfortunately, RGC program also started the same. That national average of BPL is 12.4%, but in our state, 80% of the people had the white card. And that we have a fixed package. And this is what, the CMD of RGC hospital, he keeps running fast, thinking that he's moving forward and earning money and all those things. But he did not realize that he's not progressing further, but he is there where he was. But in order to stay where he is, he has to run fast. Once you stop running, he will fall down. That is how this RGC program works. And the management, in the children, the hospital, it's a very employees is very difficult to manage them because they are very busy. They think that we are earning lots of money, but what happens, then we want to share some ideas how to manage these children with RGC, this thing with less money and all. But they think, they have in their own way of different attitudes, different mentalities and different interests. And even though we are running loss, they think that we are making profit. They don't understand what sort of troubles we had, and it is like more of like a monkey business what happens. But that's what the reality of this RGC program. But overall, look at that, it's good for the society, especially the poor patients. Good, so we can save some money and without compromising the safety. For this, it was published in the American Journal on Annals of Thoracic Surgery, and we have been awarded best innovative paper at one of the national conferences. And this is complex heart diseases like intracardiac anomalies associated with arch obstructions. We can devise a new technique. There is a single stage correction, and it was published in a European journal. And also single stage unifocalization is one of the complex cardiac anomalies. I don't want to go into its painful details, but this correction can be done in one stage. And this is what the second largest series we have and we have lots of publications on this anomaly. And I also written a chapter on this anomaly in Advances in Cardiac Surgery. The tetralogy repair in severe hypoplastic pulmonary arteries is required competent valve, otherwise, and they have pulmonary regurgitation and poor post-operative course. I have used a new technique and intraoperatively, and we create a monocusp autologous pericardium, and also we can prevent this pulmonary regurgitation. And this is how it looks like. Is like a native pulmonary wall, the competent pulmonary wall. And also we have started homograft program. It is a good armamentarium in pediatric cardiac services. And that commercially available valves are very expensive, but they are not so suitable or ideal. But after native valves, the homograft is the best suitable valves, and it is just we charge about 20,000 rupees and for the preparation charges. This is how we have established in 2008, and in that we have performed about 278 cases so far with the homograft valves. So this is the smallest child, 4 months old child, where we put in a neonatal homograft valve in these children. One is from Chandrapur from Maharashtra, another is from Kurnool. This is what, and we have another new techniques for Al-Kappa, where that I need not go into that. And that the TGA is one of the complex congenital heart anomalies, and it has multiple coronary anomalies. And the junior surgeons, he has difficulties in achieving the good results. So with these anomalies, we thought, I've been thinking about that, how we can do without any coronary translocation. One early morning I got up and I prepared this paper model and 2 coronaries, and I always have this surgical instruments in my home to practice. This was done very young age, and so I got up and cut it in such a way, and I have achieved that innovation, and without coronary translocation, that is called reallocation, and we could perform and same anatomical correction like arterial switch operation. Immediately I spoke to Dr. Cherian about that early morning 6 o'clock. He said, we will apply this technique, and we have done that successfully, and I'm really thankful to Dr. Cherian for encouraging me this sort of my innovations and my madness. And this was published in the Journal of Thoracic and Cardiovascular Surgery, and the same technique we used for the single coronary artery and transposition. Actually, single coronary artery transposition, the results are like 20% mortality. Without that, then we have more than 35 cases without any mortality with my technique. Again, is published in European Journal. And this is another complex cardiac anomaly that is called double outlet right ventricle. This is sometimes both aorta and pulmonary artery completely come from the right ventricle. That is a 200% DORV, and it's very difficult to repair, and also sometimes you require conduit. And this I have coined like a 200% DORV, and I have innovated new technique how to intraventricular tunneling and without using the homografts. And since it is a new anomaly and a new innovation, this was not only published in the European Journal, the same diagrams were put it on the cover page of the European Journal. And I have a lot of interest in teaching in India and abroad, and I have contributed a lot of establishing a lot of centers in India and abroad to do the pediatric cardiac surgery program. And also our hospital was chosen for the innovations in humanity for Johns Hopkins University, and along with this Reddy's Foundation, Nandi Foundation, and Innova Hospital. And consecutive 4 years they came and saw our work, how we are doing, and they amazed to see that how we do that such a limited resources and with an excellent result. And they have a cost comparison. This is the Cleveland Clinic, $110,000 US, and here RBC is $1,500 US. That is what the difference. And they have gone into our accounts. If it was prepared. I'm sorry for that. It is clear. Yes. This is the financial year 2013-14. And our RBC 12.9 crores, but we realized only 6.6 crores, and every year we are waiving off our concession about 6.6 crores, and that means every year $1 million, like 10 years almost $10 million. Of course, if you compensate it with the donations and all, it is good, but we could not mobilize such a donations so it is intellectual paradox. Pediatric cardiac surgery is an intellectual paradox. Even a good surgeon, you produce good results, but you have to go with a begging bowl to save these poor children. How many people can do this? And this is our hospital. At any given time, you see that all poor children come here with breathing faster, low birth weight, and emaciated, and all those things. This is how we have to take care of these children. This is what Swachh Bharat I was talking about. And with these limited resources, even our results are on par with any other Western world. And so you look at that need for the pediatric cardiac centers in India. The incidence is 8 per 1,000 live births. That means every year more than 2 lakh children are born, and less than 10% of the children are getting the treatment. According to the American College of Cardiology recommendations, we should have one pediatric cardiac center in 5 million population. That means India needs more than 200 centers, but hardly we have about 20 centers in the country. But fortunately, and in Hyderabad, we are above national average, and but the rest of the country it's much miserable situation. And this slide shows that we can learn a lot from the nature. One day my wife pulled me to this bonsai exhibition. There, that scientist was talking to the housewives, how you can make bonsai, a small plant out of a banyan tree and all. And these bonsais are, they are the cute pieces in the house. Then when I come out of that exhibition, I think there's a lot of similarity between the pediatric cardiac services and the bonsai. And why? Because many centers in the country wanted to have a pediatric cardiac services, but they don't want them to allow. They don't want them to allow. I am sure that you are hungry, but I wanted to share some important message with you. And they don't want them to grow bigger. But what pediatric cardiac services think about it is that I also want to grow like other specialty, and also establish centers where this is not available. So that's, we have to have a full potential. That's what the government hospitals or corporate hospitals, to encourage these centers to grow in full-fledged, financially viable thing. So what is the major innovations we wanted to make is that high volume, high quality, cost effectiveness without compromising the safety, and we want to establish more centers and train more medical professionals, and also engineer the medical equipment to reduce the cost, and subsidize the medical treatment to the poor, and financially viable, and make it cheaper to reach to the masses. So, dear friends, you know that most of the congenital heart diseases are treatable and can lead normal life after surgical intervention. Need awareness in the society and medical professionals, and also it is young specialty, and you have to have a different consideration to grow in adult specialty. Require many centers, not only India and other developing countries, and it would be a business model with a social cause. And this is the child we have operated at the age of like 15 days to 2 kilograms and flown from Nagpur, and he had arterial switch operation, and I have seen recently. Thank you very much for your attention.
Thank you so much, the chairpersons, Dr. B.V. Ramarao and also Dr. Prasad Reddy Garu. And now I would request Dr. Ram Mohan to come to the stage and to honor our speaker, Dr. K. Sambamurthy Garu, with the memento.
Dr. Ramarao, if you
so
want
chairpersons, please do join them.
So much hard work, frankly, amazing talent, but my heart aches when I see these facts. Hello? See, all surgeons should be united, because the low-cost package is really killing the industry, and many surgeons are not opting. It's a total sacrifice, frankly. So I think Cardiological should think about this, like Argosy schemes, particularly for complex congenital and high-risk coronary bypass surgery, open heart surgery, particularly LV dysfunction and everything. Few comments, Anna.
I think Dr. Sambamurthy, as a cardiac surgeon, I hats off to your fight against great odds to deliver this pediatric cardiac surgery of quality. I understand the odds and the pain in the heart to deliver for a socially deserving poor people. Argosy is one aspect, but the most important thing is the day in and day out commitment to help these kids. I think all of us should have a standing ovation for his efforts. I think as a cardiac surgeon, I'm very proud of his contribution to the state and also the training programs. And I can say, I'm very proud of his work, and congratulations. And I hope definitely God will open up the path for you to continue more work to the help of the society. Thank you.
lunch is going to be there. We shorten the time, 20 minutes. Please, after the lunch, come and join for the next sessions. Thank you.
Please join after half an hour.